Buenos dias. My name is Alex Bejarano, and I have the honor of being your Master of Ceremonies today for the 7th Annual ABRC Conference brought to you by the Regional Center for Border Health, Northern Arizona University, Arizona Department of Health Services, and Western Arizona Health Education Center. It's my distinct honor this morning to introduce to you a few of our guests that will be giving you the official welcome. Ms. Amanda Aguirre, President and CEO, and former Arizona State Senator, the first male or female Hispanic ever elected from this district to the state Senate. And
Thank you, Alex. That makes a difference, right? Female and male. So yes, first Hispanic. Very proud of that. Thank you very much. Good morning. Buenos dias a todos. Welcome to our friends from Mexico. Bienvenidos, nuestros amigos de México que están aquí de Baja California y de San Luis Rio Colorado, Sonora. So it's such a pleasure to be here this morning to welcome you to the 7th Annual ABRC Forum, Yuma County Forum. It's been an incredible path and road to get here. I know a lot of discussions. I was speaking to Dr. Stephen Palmer about the reports that had come out through these years, even through COVID. And it's been very powerful to see that the communities that we all are so resilient to continue working in the very much complex issues that our families and communities face. And of course, the agencies that we all work with and the challenges that you take home and to work and to come out with innovative solutions to continue continue serving the families that we care so much. Today, we're going to have an amazing group of guest speakers today. And but before we move on to my co-chair of this or co-welcome guest, Dr. Savit, I want to make sure that I thank my staff because I think my staff are all standing up. I know Alex, you already met Alex. Maria Jose standing in the back. Where's everybody? My IT personnel is in the back. Philip, they have to do with Andrea. They have to do with all putting together this event. The pamphlets, yes, they deserve it. So the logistics to put something together, they're not easy, and especially working with me that I like everything to be perfect. So it's not easy, but they always do an amazing job. I want the planning committee members to please to stand up. Dr. Linda Elliott is here, so please everybody, my staff is here. Not everybody's standing up. There you go. Thank you so much. They're part of this planning committee every year, giving us the best feedback and input to make this event the best for you, the best that we can provide for all of you to facilitate a great discussion for this morning. And so thank you again and welcome and have a great time. And we're all here to create ideas as we move it into the new future. And we got to see the brightness in the new future. And we know there is the light after the storm, but we're going to get there. So thank you so much. Enjoy your evening.
thank you, Ms. Aguirre. Dr. Michael Savit, Dean and CEO of Northern Arizona University Yuma Campus. Mr. Savit is the Dean of the Northern Arizona University and Campus Executive Officer for NAU's Yuma Branch Campus. He earned a Bachelor of Science in Business Administration from the Haas School of Business at the University of California, Berkeley, and an MPA from the California State University, and a PhD from the Graduate School of Public and International Affairs at the University of Pittsburgh, Pennsylvania. Dr. Savit was with San Diego State University for 23 years, serving as a professor, division chair, and associate dean. Prior to this, he taught in the School of Business and Public Administration at the University of Missouri, Columbia, and at Indiana State University, Bloomington. His research has focused on public policy and management and issues related to the justice system and transnational cooperation. Please help me welcome Dr. Michael Savit.
Thanks, Alex. You know, Amanda, you always do a knockout job. And, I love the music. That was a nice touch. I truly appreciate it. Good morning, everyone. I want to welcome you as well, and sincerely thank you for being here this morning. It's exciting to gather here again with our fellow stakeholders in our commitment to addressing health inequities in our communities in Yuma and the surrounding border region. This marks the 7th annual ABRC Forum. I'm amazed that it is the 7th. I look back at what we did in year 1. I'm trying to think, we documented a lot of this, but we've come a long way, and it's sometimes hard to see progress, but we have made progress. We're focusing again on some major themes. The one today is developing a diverse workforce in healthcare, but we also focus on issues related to binational border health, community engagement, and clinical and community health research. The forums have always been more than just an event for me. They serve as a platform for discussion and ideas, and hopefully they operationalize into practical strategies and solutions for addressing health inequities in our community. I was reflecting on what the ABRC Forum meant to me over the years, and there were 3 areas that came to mind. The first one was the people. We have a great collaboration. We have people from all kinds of organizations and institutions. But I think what I appreciate the most is our collaboration with our colleagues from across the border, particularly the educational institutions, but others as well. But we work closely over the years with UABC, Mexicali, but Guadalupe, Victoria, and I see Gilberto here from there, but CETIS, UES, Sonora, and many polytechnics and tecnológicos. So I really think that's a major advantage of this meeting and the networking that goes along with it. But apart from that, I do enjoy seeing the developments and expansion of our healthcare workforce, both in the university setting, but other settings as well. We've come a long way with personnel in the area of medicine, nursing, mental health treatment, home care, on a variety of fronts, social work, and I'm really proud of what we've been able to do. And from the standpoint of Northern Arizona University, what we've been able to contribute to Yuma and the surrounding region. We've done a lot in that respect, but I also know that just increasing the numbers of health care personnel isn't going to do it. We have to go beyond that. I think back when the first proposal I ever wrote, I did a proposal for the Health Manpower Council in Northeastern California years ago. And they had a problem of recruiting physicians and allied health personnel into rural areas. And when I first looked at it, I said, this seems to be fairly straightforward. It's a shortage. We had a problem of a shortage. And then I found the federal government, state governments over the years had really worked hard to increase the number of personnel in these areas, and nothing happened. It was really disappointing. What we found was increased specialization, more people in the cities, in the healthcare profession, and so on, and nobody came out to the rural areas. So I think, apart from enjoying seeing what we're doing with respect to health manpower in our region, I'm really interested in seeing sort of a reconceptualization of how we approach health disparities in our communities. And coming up with ways to maybe work smarter or to structure problems more completely and adopt new strategies and practices that make us work better with what we have rather than just trying to increase the numbers of personnel. And, last year I listened to Rudy Ortiz here from First Things First talk about community resource centers. And he's been preaching community resource centers for a number of years. And I think he's really onto something. It's a different kind of an approach. It's a more holistic approach to dealing with healthcare. And so I really enjoyed that. So those are things that I take from the ABRC Forum and enjoy most about it. In any case, your participation and commitment is critical to the success of the forums. And of course, the continued support and sponsorship of the Arizona Department of Health Services Arizona Biomedical Research Center, because they really have stepped up for 7 years now, as well as the Regional Center for Border Health with Amanda Aguirre, NAU Center for Health Equity Research with Julie and colleagues, as well as University of Arizona. They've done an awful lot to keep this going, and I'm really pleased to be associated with the Annual Forum. So once again, welcome. Thank you for your commitment, your insight, your passion for advancing health equity in our region. We're glad you're here. Thank you much.
Before I introduce our next speaker, I'd like to just point out a few housekeeping. The restrooms are through this door, or you can go around through the other side as well. And I'd like to also recognize a few elected officials that are here today. Ms. Maria Chaboya with the Arizona Western College Board of Directors. And Ms. Lorena Delgadillo, Vice Mayor, City of Somerton. And I'd also like to acknowledge that today is the Vice Mayor's birthday, so if you'd all wish her a big round of applause for her birthday. Our next speaker, Dr. Steve Palmer, Northern Arizona University. Dr. Steve Palmer is a professor in the Department of Health Sciences at Northern Arizona University. Steve's primary research centers around physical activity promotion through physical education, specifically curriculum and I'm sorry, I'm gonna mess up that word. Pedagogical methods of promotion methods that contribute to individuals becoming and remaining physically active. Dr. Palmer earned his bachelor's and master's degrees from Chico State University in Chico, California, and his doctorate in curriculum instruction from Virginia Tech in Blacksburg, Virginia. Steve has worked at Northern Arizona University since 2001. Please help me welcome Dr. Palmer.
Thank you. Hey, thanks, Alex. And good morning, everyone. It's good to see folks here. Let me see if I got my slides right. Yeah, am I able to advance? Well, so once again, I'm going to echo many of the comments that you've heard already. Welcome to the 7th Annual Forum. And of course, this year we are focusing on a diverse healthcare workforce. Let's see, I'm fortunate to work with so many brilliant, amazing folks that are there really trying to do things that make a difference for the communities they serve. So this forum, I do want to share, let's see, am I able to do this? Yeah, there we go. Yeah, this forum is, a lot of funding comes from the Arizona Biomedical Research Center. So I'd like to thank John Garcia, who you'll hear from shortly, as well as Keelan McCool for their support. And of course, thanks to Ms. Aguirre and the rest of her team for all you do to make this such a wonderful event. So you're truly an inspiration to us all, so thank you. I'd also like to thank Doctors Julie Baldwin and Robert Trotter. So Bob wasn't able to come this year. He really was one, and you'll hear more about him soon. He was one of those working with Mike Sabbath and a handful of other folks that really started bringing folks together as part of the forum by bringing the right people together. So we missed Bob this year. But yeah, and thanks to the Center for Community and Health Engaged Research for their efforts to address health disparities and then improve the health of people from all communities. And, once again, there are so many other people involved that, would just like to thank you all. I can't name them all. So I do want to share, I'd like to share some of the other workshops that we are hosting this year. So the ABRC funds 5 educational related workshops that deal with the health of folks who live in Arizona primarily. So we've already hosted 3 so far this year. The first was on harnessing health data using the All of Us database. So if any people out here are really interested in diving into data to look at any kind of correlates of any kind of health related data, it's an amazing project. And that was led by Pam Buzzard from NAU's Klein Library. So we really examined opportunities for research using that database. Then on February 28th, we examined efforts to coordinate services for individuals struggling with addiction. And we see some of the posters downstairs as well that are right in there with that topic. Dr. Jen Kahn, who is the CEO of Flagstaff Medical Services, she spearheaded organizing that workshop. And it included providers from Crossroads down in Phoenix, Flagstaff's the Guidance Center, Northern Arizona Health, North Country, and many other agencies. Then on March 28th, Dr. Joe Mihalchek, he brought together tremendous scholars to present research and opportunities using spatial and epidemiological modeling for disease modeling and public health. And, as I looked back at some of the past Yuma forums during the COVID years, that research that Joe is really kind of moving forward is related to some of what we had started to investigate or expand on during the COVID years. Then looking ahead on May 30th, we've got a follow-up called Beyond BMI Part 2, and it's a weight-inclusive approach to optimizing surgical health and health outcomes. And we've got faculty from NAU's physical therapy department that are bringing together people to go through the research on the importance of strength training as opposed to saying lose weight before surgery, and looking at really health outcomes and behavior change. So that's where we're going. But today, I thought, and we've heard from Amanda, and also Mike kind of mentioned some of the history and where we have come from with this forum. So I did a deep dive. I went back and looked through all the past presentations and the reports and some of the videos of the past workshops, because I was like, how did we get here? And it all really started in 2017. And Bob Trotter had come down. He got connected with Amanda. Julie was there. Mike was there. And all these folks. Alex was involved. We had Jason Bradley from NAU Yuma, John Bowles, Gloria Coronado, Maria Chavoya, Mike Saville, I mentioned Edgardo Figueroa, Diana Gomez, Naomi Nichols, Rudy Ortiz, Emma Torres, and Amy Jalad, who was with CHER at NAU. And they said, let's come together. What can we do to bring a forum and people together to talk about health equity through collective community action? And that's where it really started. Then the next year was the second annual, and it really was in 2019. And the theme of the forum was improving health equity through collective community action. And the objective, as you can, I don't know if you can see on the screen, was to identify actionable strategies for improving health equity for the population in the southwestern Arizona-Mexico border region. And this was at the Pivot Point Center, the conference center, and it brought folks together. And there were 3 work groups that emerged or that were put together to discuss this topic at that point. One focusing on binational health, and some of the recommendations from that task force or that work group included developing binational early childhood nutrition programs and careers. And some of the things that we've seen in posters, I don't know if they were born at that point, but they definitely connect with many of the things we've seen in the posters downstairs if you haven't had a chance to look. The second core was the health community engagement. And then the third one was on workforce development. So we saw what we're going to discuss today. It was talked about back then as well. Then, of course, the pandemic hit and we had our COVID years. So for the next 2 years, this forum moved to be online. In the third year, we had research, primarily research presentations on strategic priorities for developing health research capacity in the border region. So we had Dr. Baldwin. She shared research or research narratives, initiatives through NAU and throughout the state. Diana Gomez, who talked about Yuma County testing during the COVID. Dr. Tal Pearson, he talked about disease spread. Frank Von Hippel, who I understand is at U of A now, he discussed environmental toxicants, which once again, we see some posters downstairs expanding and doing more with that work. And then Crystal Hepp, who's now with TGen, she discussed some of the issues with West Nile virus. Then in the 4th annual in 2021, we had it was looking more at, hey, how are we responding to the pandemic? We had a welcome from Senator Mark Kelly. Then we had other speakers that really took a deeper dive into what was our response to COVID in the region. And on some levels, many of the things that we saw here from you all in this community were model reactions to, or responses to what the rest of the country could actually follow. So that were the scholars there. So then 2023, we came back together, and this was the first year I got involved with this, and I'm fortunate to be there. And we were back at the Pivot Point Center, and it was saying, hey, let's come back and do another annual review of community engagement and that collective approach to action. And this is where we had a fourth, the research working group emerged at this conference. So it kind of expanded from the original three. And then that's where Bob Trotter and different folks led discussions, and some of the recommendations from that fifth annual are in a tremendous report. And I believe it's available online. If not, we really need to make sure it's back available again. But we looked at binational border health again, community engagement, clinical and community health research-based research, and then workforce development again, because that is a challenge, as we know. So then the following year, of course, we came back, and this is where we took the research another step. So we looked at strengthening partnerships to sustain healthy border communities. And this was the first year. Last year was the first year where we included the poster sessions and the tables of resources from community resources. So, and there are many folks here today that brought in have displayed their posters and resources downstairs. So thank you all. And then the roundtable discussions, we actually had a vote last year. We took the themes that emerged from the posters that had been presented, and we identified 5 different themes, and those were youth support and mental health, community violence and cross-border challenges, family resource centers, culturally responsive programming, and access to services and information. And the folks that attended last year, and many of you were there, we actually voted on the priority, and most of the discussions during our roundtables actually surrounded youth support and mental health. And once again, we see that emerging downstairs in the posters this week as well. So that's where we came from to now today. And the discussions, the presentations today are really going to focus more on just developing a diverse healthcare workforce. There are so many challenges. So why do folks not return to their communities to work in the healthcare fields or in facilities in those rural areas? Some of it is finance and budget, the amount of money folks make. Part of it is maybe recruitment from those areas, so folks can go back to the communities in which they grew up to then serve those communities. So we're going to hear more on that today, and it's exciting. So really looking forward to the roundtable discussions. We will have another vote today on what our priority discussions will be. And really, we're looking forward and excited to see what you all come up with as far as those next priorities and maybe steps, maybe out of the box, thinking out of the box steps to help develop that rural healthcare workforce. But I'd like to do a little activity. I know we all ate, so we're going to get up a little bit, but I'm asking that if you're able, if you have been here for all 7 of these workshops, would you please stand? There's a number of folks. Thank you. Okay, but please remain standing if you have been here for all 7. Okay, now, thank you all. Remain standing, please. So now, how about if you've been here for 6? Okay. How about 5? Please stand and join us. Okay, Gustavo. Okay. 4. How many of you have been here for 4 of these workshops? And I'm in that group. I'm in with 4. Okay. How about 3? You. Right. 2. How many of you, is this the second one you've attended? Okay, perfect. Thank you. And there's more, and we're growing. And then, of course, everybody, if this is your first one, please stand. Okay. Please look around and give yourselves a hand, because you all are the folks that are doing the work. But while you're standing, I want to tell one story. We're going to wait and let the blood flow. While you're standing, I want to tell a story about Dr. Bob Trotter, who really was the early instigator of this event. So I have a colleague who came to NAU about 12 years ago, and he came from a small institution where you could just do whatever you want. You didn't have to go through all these systems to get things done. And he gets to NAU and he meets with Bob about trying to do his research. And after about 10 minutes of my friend talking to Bob, Bob stopped him and said, you know, I've listened to you for 10 minutes, sharing all the challenges and reasons why you can't do research and why you can't do this. And then he said, now I want you to tell me what can be done. And that came from Bob. And when I look around the room, and if you look at your colleagues and friends here, you are the people who get things done. And I just want to say thank you for being here and for doing all the work that you do in your communities to really make life a better place for all the people that we work with, live with, and love. So thank you all very much and enjoy the day today.
Thank you, Dr. Palmer. Before we continue, I'd also like to acknowledge the presence of Miss Maricruz Granillo, who's representing the Mexican consulate in Yuma, Consul Dulce Maria Valle Alvarez. Thank you. Our next speaker, Dr. Julianne Baldwin from Northern Arizona University. Dr. Julie Baldwin is the and I'll let her explain what NARBA means. Is the NARBA Institute Vice President for NAU Health, the Executive Director of the Center for Community Health and Engaged Research, CHER, and a Regents Professor in the Department of Health Sciences at Northern Arizona University. She earned her doctorate in Behavioral Sciences and Health Education from the John Hopkins Bloomberg School of Public Health. From 1994 to 2004, she served as a tenured faculty member at Northern Arizona University. She joined the faculty at the University of South Florida College of Public Health in the Department of Community and Family Health in 2005. She returned to Northern Arizona University in August of 2015 to be the founding director of CHER. Dr. Baldwin's research over the years has focused on both infectious and chronic disease prevention. Dr. Baldwin has had a consistent program of applied research addressing HIV/AIDS and substance abuse and prevention in youth, with a special emphasis on working with American Indian youth and their families. She continues to contribute significantly to this field of research today as the MPI of the NIDA-funded Research Education Grant. She is also the principal investigator of the Southwest Equity Research Collaborative, a U54 NIMHD-funded research center. She was inducted into the National Academy of Medicine in 2023. As a citizen of the Cherokee Nation of Oklahoma, she has made a lifelong commitment to advocating for health promotion programs for children, adolescents, and families. Please help me welcome Dr. Baldwin.
Thank you so much, Alex. And it's such a pleasure to be here today. Thank you again for inviting me. I wanted to, first of all, thank Amanda and her team with the Regional Center for Border Health for doing these amazing workshops every year, and our partnership with Regional Center is so important to us. And I know Steve stepped out for a minute, but I also want to thank him for a wonderful presentation about the history of the ABRC workshop series, and is serving as a leader for this program for the last couple of years. And then thanks also to the planning committee and also to the ABRC for funding this program. So I'm going to tell you a little bit about both our Center for Community Health and Engaged Research at NAU and also what's happening with NAU Health. So I'll start with our center, and we did have a change in our name, but our mission and vision remain the same. So our mission is to collaborate with communities to build foundations and environments that support health and well-being. And our vision is to be a trusted partner and leader in research and action to attain the highest level of health for all people. And we really focus on a number of different areas of research priorities. We do chronic disease prevention work and treatment in terms of looking at cancer, diabetes, and obesity prevention. We've worked in the area of infectious disease prevention, especially COVID-19 and HIV and STIs, maternal and child health, environmental health, and indigenous country, but also here in Yuma and along the border. Behavioral health, really focusing more on substance abuse, mental health, and suicide prevention. Oral health, specifically looking at preventing early childhood caries in young children, and then disabilities and Alzheimer's disease and related work there with aging. I think everyone's very familiar with this term, so I'll just briefly state that This, of course, is very important to us and central to the work that we do in terms of health equity. And health equity has been defined as the assurance of the conditions for optimal health for all people. It requires valuing all individuals and populations equally and recognizing and rectifying historical injustices and providing resources according to need. Health equity also involves every person in every sector. So it's multi-sectoral, and this is also very important to us when we think about the social determinants of health and how all of these things influence health equity. So I wanted to tell you a little bit more about a particular project that we've had for the last several years, funded by the National Institute on Minority Health and Health Disparities. It's called the Southwest Health Equity Research Collaborative. And this program has been really designed to help increase basic biomedical, clinical, and behavioral research at NAU, but also with our community partners to address and promote health equity among diverse populations here in the Southwestern United States. These are our core goals, and these, I won't go into a lot of detail, but I just wanted to illustrate that this is a very large type of grant that involves multiple cores. So we have an administrative core, research capacity core, investigator development core, community engagement core, and a recruitment core. And the administrative core is really focused on trying to bring all of the cores together and to coordinate those activities. We have a core leadership development program. We really focus on strategic and collaborative partnerships, also team science and translational research, and then the evaluation portion of the project resides in this core too. Then for our research capacity core, we are trying to provide methodological, statistical, and informatics support for our investigators and again, our community partners to maximize productivity of research. Then we have what's called an investigator development core, as I mentioned, that fosters research career enhancement for especially underrepresented investigators and early stage investigators. And then our community engagement core is really focused on engaging community-based organizations, leaders, policy experts, and researchers to develop relationships, to take action, reflect, and enhance community needs and assets. And then finally, we have a recruitment core that's really focused more on building our faculty base at NAU and bringing on more faculty that specialize in health equity. So we have three major research projects currently as part of this grant. One of them is led by Dr. Ricky Camplain, who's looking at gender differences in physical activity and that the impacts while people are incarcerated. And then another individual, Emily Cope, is looking at fiber as a strategy to decrease asthma morbidity in underserved populations. She's working with children. And then the last investigator, Joe Mihaljevic, is looking at different dynamics to improve spatial models of infectious disease. And we've had several key accomplishments over the last several years. And I just wanted to emphasize this because I think it speaks to the fact that it's really important to have these types of infrastructure building grants and opportunities within an institution and the impact that it can have also for community partners too. So over time, we've had over 43 different research projects funded through this particular grant. 8 have been like full research projects, 28 or 26 pilots, and then some supplements. We've had over 115 faculty and postdocs involved at NAU. And then the return on investment has been really significant in terms of these smaller grants leading to larger grants, again, that are very much focused on health equity and working with community partners. We've had a lot of really exciting things happening through our community engagement core, and I'll share some of that. And then I guess the highlight is that we have now achieved at NAU what's called R1 status, which means the highest research status we can achieve there. So it's been very exciting to get to this point over the last couple of years. So just to tell you a little bit more about some of these cores, because I think they might be of interest to you, the investigator development core is really like a seed project. It's a pilot project. And we really do try to ensure that our investigators, again, are working with different community partners around the state. It's very small grants, 50,000 a year for 2 years, but with that money, they actually can do a significant amount of work, and these often lead to other grants and projects too. And then, as I mentioned, our community engagement core is very important to us. The focus there is cultivating and expanding relationships with multi-sectoral, community-based organizations and leaders to really try to identify locally identified health concerns. And we do that through a number of activities, which you can see here. And I really wanted to emphasize the community engagement studios because I think this is something that's a little bit more unique. These are studios, they're 90-minute sessions that allow the researchers to work closely with our community partners and organizations to start to prioritize the research goals for that organization or that group. And then to do some other things too, which might involve developing culturally relevant instruments and interventions, and then to look at how do we strengthen our recruitment and retention efforts in programs and studies, and then how do we disseminate those results in the most appropriate way back to the community. We also have a technical assistance group service center, and I wanted to highlight this because previously it's been focused more on serving NAU folks, faculty, students, staff, but we are now expanding and we want to work very closely with community partners on this too to offer some of these services. So I don't know if some of your organizations might be interested, but we provide statistical analysis support in terms of research methods, power analysis, things like that. And then also non-numeric data, so qualitative studies, interview development, social network type of studies, community-based participatory research work, and then survey development and software utilization too. And Dr. Monica Leininger is our director for this particular service center, and I'm happy to share more information with you. Her email is down below as well. We also offer some workshops, additional workshops, some of them internal, but they're often in person or virtual and then recorded as well. So we have that whole bank of workshops on our website. And we also offer trainings, in particular software training too, that might involve different types of analysis. And then finally, we have some support for data tools and infrastructure. And again, mostly at NAU, but we're getting to a point where we, of course, want to partner more. We have been partnering with community agencies, especially looking at publicly available electronic databases and using those databases to help us do program planning. So I wanted to turn now in the last bit of time that I have to NAU Health and tell you a little bit about where we're going with that as well. And I think most of you are very familiar with, as Steve mentioned earlier, and others have mentioned, some of the healthcare gaps. I know Mike talked about that too. These are just a few of the statistics that came from Arizona Board of Regents report in 2022. And I won't go over all of them, but just to highlight a couple, that Arizona's worker to population ratio is below the national average for all health professions, except for pharmacists and chiropractors. And as we all know, rural counties experience greater challenges recruiting and retaining healthcare workers. And public health funding is also 50% below the national average, putting us at 47th across the United States. In terms of trying to address these needs, these are the numbers that the ABRC projected that we would need to be able to fill these shortages. So you can see across the board for nurses, physicians, behavioral health workers, dental hygienists, physical therapists, and then occupational therapists. So we would need these numbers to fill the shortages by 2030. And so a large part of this initiative called NAU Health was really inspired by some of these concerns and facts. And we want to try to improve health outcomes for Arizona's rural and underserved communities. And our goal is to try to double the number of healthcare profession graduates. We also hope to launch a medical school, and I'm going to talk a little bit about that as well. So before I talk about the College of Medicine, I just want to mention that we now have a College of Nursing. Previously, it was a School of Nursing. And we are working very hard to strengthen our partnerships, alumni relations, and expand the programs that we offer through nursing. And then we also have a strong focus on behavioral health professions too. And I'll tell you more about that at the end of this presentation, but we want to be able to strengthen especially our partnerships with community colleges, with tribal colleges, and develop more interprofessional programs too. So that's our focus there. With the College of Medicine, and we've had several meetings, and I'm going to tell you about that history. But our overall goal is to have a very teaching-focused College of Medicine that's really also focused on primary care, that hopefully offers eventually, maybe not initially, some accelerated pathways and affordable options, and that it's very partnership-driven with an integrative curriculum. And this is the vision as we have it now in terms of our College of Medicine. And I think it's well known that NAU has provided a great deal of leadership in the state in providing educational access and achieving high levels of attainment and serving first-generation students and those from diverse backgrounds. And so this has really inspired our vision for the medical education, and our goal is to try to integrate existing excellence in behavioral health, public health, and health equity and health sciences to create a College of Medicine that would be founded on strong partnerships with providers and communities and designed to prepare our physicians to meet the healthcare needs, especially in rural, underserved, border, and indigenous communities around the state. And as I mentioned, we've gone through several processes of trying to obtain input from different stakeholders. We did form a medical education advisory committee last year and met with them with statewide representation, also national members who are assisting us in terms of looking at national trends in medical education. We formed a local provider advisory group as well in the Northern Arizona area. And then we were able to meet with some consultants who helped to develop the UT Austin School of Medicine, as well as the healthcare system there, to really think about what are the main design elements that we want to see in our College of Medicine. We've had an opportunity to meet with other deans of colleges across the country who are doing things very similar to what we want to do. We've talked to the accrediting body, the LCME group. We've also met with our sister institutions, University of Arizona and ASU, and had some great conversations with them about collaborating on this effort too. And so one of the main goals is, as I mentioned, that it really be community driven. And our aim is to recruit students from rural, under-resourced communities that really want to train, serve, and stay in their communities to help improve health. And that, of course, involves pathways, clerkships, residencies, and I'm happy to have a group at my table that I can talk to more about this. It also may involve innovative teaching methods. So such things as case-based learning, evidence-based medicine, problem-based learning, simulation-based learning. AI now is a big issue or factor that we have to consider, e-learning, and then peer-assisted learning and observational learning. And so these are some of the main design features that we see as really critical in moving forward. So first of all, I've already mentioned the emphasis on primary care, also rural and tribal focus, and then integrated care, meaning behavioral health, mental health integrated if possible into the curriculum as well, and also more interprofessional educational opportunities among all of the healthcare professionals represented. Trauma-informed care. We're very interested in longitudinal integrated clerkships as compared to more block-based rotations. And then, as I mentioned, leveraging technological advancements. We are still in the very early stages of really planning this College of Medicine. We hope to have support, of course, from the state and Arizona Board of Regents to be able to keep moving forward. And as I mentioned, what our focus is right now is really trying to develop clinical and community partnerships to really be able to develop this further and sustain it along the way. So in the last couple of slides, I just want to share with you what we're doing in terms of behavioral and mental health too, because this is a main area of focus for us as well as part of NAU Health. This has a lot of information on it, and I apologize, but this is just illustrating all the different colleges at NAU that have some type of behavioral or mental health program, whether it's a degree program, a certificate program, or some type of training program. So we've done an inventory of all of these programs, and now we have formed a behavioral health advisory committee. And I would love it if there might be some in the audience who would be interested in becoming a part of this behavioral health advisory committee. We've met once or twice now, but we're planning a larger meeting this summer in Flagstaff in June or July. And what we're really trying to do is determine how NAU's programs can best be modified and enhanced to serve the workforce needed to carry out this work across the state and to really help the workforce develop the skills and competencies needed so that we align our programs better with, again, what the needs are throughout the state. So we hope that we'll be able to actually have another ABRC conference focused on this, possibly in the fall. And again, I'd welcome any of you that might want to participate and attend. And with that, I'm going to say thank you so much and happy to answer questions at the end. Thank you.
Thank you, Dr. Coleman. Our next speakers, Mr. John Garcia from the Arizona Biomedical Research Center, Arizona Department of Health Services. Mr. Garcia, a second-generation Arizonan from Tucson, has dedicated over 40 years to public service, showcasing a diverse skill set across various roles within Arizona state and county government. Currently serving as the program director of the Arizona Biomedical Research Center, John's tenure with the Arizona Department of Health Services commenced 5 years ago. His career with public service has been multifaceted, encompassing positions such as policy analyst, research and budget manager, grant administrator, procurement and contract manager, financial controller, IT business analyst, project manager, and public safety dispatcher. John's academic credentials include an earned master's of business administration with a specialization of information technology administration from Ashford University, now the University of Arizona Global Campus, complemented by a bachelor's degree in management from the University of Phoenix. To further enhance his professional foundation, he obtained a certification as a public manager through Arizona State University's esteemed Advanced Public Executive Program. At the helm of ABRC, John Garcia oversees the allocation of grant funds to biomedical researchers and Arizona universities, facilitating education initiatives for faculty, staff, students, and the public. Additionally, he adeptly manages the Arizona Public Cord Blood Program, contributing significantly to advancing biomedical research and healthcare initiatives within the state. Please help me welcome Mr. Garcia.
Thank you. Good morning. It's an honor to be asked to help kick off today's 7th Annual Yuma County Forum entitled Closing the Gaps in Health Disparities, Developing a Diverse Healthcare Workforce. On behalf of the Arizona Department of Health Services and the Arizona Biomedical Research Center, thank you for joining us today. The program for the second day of this forum is designed to provide us with timely and relevant information to help guide the development of a future healthcare workforce that can respond to rural Arizona's diverse needs and reduce disparities in the care of all Arizonans. My thanks to the Honorable Amanda Aguirre and the Regional Center for Border Health, to Dr. Michael Sabath, Associate Vice President of NAU's Yuma campus, Dr. Steve Palmer, Professor with NAU's Department of Health Sciences and the Center for Community Health and Engaged Research, your hosts for today's forum. With this conference, I must sadly bid farewell to Dr. Palmer as he transitions from his leadership role at CHER to his new role in health sciences. Steve has worked tirelessly for the past couple of years to host many exceptional educational events for faculty, staff, students, and the public. And he's going to be missed. I wish at the same time to welcome Dr. Julie Baldwin, whom you just heard from as she takes over a broader role in the Health Sciences Department and as Executive Director for CHER. Thank you, Steve, for embracing ABRC's vision for research education and your help in raising the bar for quality educational events. I look forward to future collaborations with Julie and the CHER team. And based on what she just talked about, I'm looking forward to that because we have a lot of work to do, and I plan that that we'll be able to work together for many more years as NAU develops its health sciences programs, the College of Medicine, nursing, and the research part of it, because that's, if it isn't for the research, there's so much that we would not know about just medical science, disease, and the various treatments that get developed so that people can lead healthy lives and receive the best possible medical care. The Arizona Biomedical Research Center is happy to sponsor this workshop. NAU, as you've heard from Steve, received several research education grants from the ABRC over the years, and really has not disappointed us in the quality of the programs hosted and provided. Under the leadership of Dr. Victor Waddell, the Executive Director of the ABRC and Chief of the Arizona State Laboratory, this program was added to fall under our 3 program areas of ABRC. Through the Research Education Program, the ABRC provides funding for the state's universities to host workshops like this, symposia, and conferences to help keep students, researchers, faculty, staff, and citizenry abreast of the latest in biomedical research. Additionally, the ABRC provides grants to organizations and individuals to conduct cutting-edge biomedical research that will eventually be translatable into the treatments and cures of tomorrow. Finally, the ABRC is host to the Arizona Public Cord Blood Program that strives to collect cord blood from a diverse population to save lives through transplantation of cord blood stem cells. To date, over 101 cord blood units from Arizona have been used in transplant procedures. And I'd like to extend an invitation to anyone who is desiring to join us this coming Thursday for our 10th annual cord blood conference to be held in Scottsdale at ASU's Sky Song Innovation Center. If you were to go to our website, you would find that the registration's closed, but if you're really interested in it, you're welcome to reach out to us at cordbloodinfo at azdhs.gov. That's cordbloodinfo at azdhs.gov. And send us a note, and we'll do our best to at least add you for a virtual to join us virtually on Thursday. We have several other events coming up. I just let you know about. Beside the cord blood conference on the 17th, we also have on May 8th the ABRC and Flynn Foundation research conference to be held at the Arizona College, University of Arizona College of Medicine, Phoenix, at the downtown Phoenix biomedical campus. And that is on the 8th of May and is part of an all-week conference that is being held, and it's going to be very exciting. This is something that I've wanted to do for several years, is to put together all the topics about biomedical research, translational medicine, and put it together in a very larger setting. So if you are considering attending that, you can get registration through our website at azdhs.gov/biomedical, and you can get to the event there. And we'd love to have you there. Also on June 6th, Banner University Medical Center is hosting a Department of Medicine Healthcare Advancement Symposium, June 6th from 8 a.m. to 1 p.m. And it's going to be at the University of Arizona Banner Educational Amphitheater at 1111 East McDowell. And on our website, you can get to the link there to register. And of course, you've already heard from Steve about their upcoming event on they're called Beyond Weight, Optimizing Surgical Success Through Strength and Health. And that's going to be up at their Flagstaff Medical Center, the McGee Auditorium. And you can register off of our site if you would like to do that. Well, I want to thank you. I wish I could be there today with you. Unfortunately, I'm dealing with a family medical crisis of my own, and I had to stay here in Phoenix to do that. But I will be there with you in spirit, and I thank you again for this time. And let's sit back and enjoy today's forum and make the most out of it. This is an exciting time for us. Our workforce in the rural areas of Arizona for healthcare is in dire need of help. We need to attract not only just people, but good quality people who have the passion and desire to provide the best quality level of health care for our rural Arizonans. And so have a good conference, and I hope to be with you for next year's conference. Thank you very much.
Thank you to Mr. Garcia. We're doing really great on time, so we have a lot of time for questions. If anybody's interested in asking the panel a question, one of our IT colleagues is going to be walking around with the microphone. If you want to please stand if you have any questions for anybody.
Thank you. Good morning, everyone. My question is for Dr. Julianne. I might be interested in listening a little bit more about the Behavioral Health Advisory Committee. What are the main aims of this committee, and what are the long-term aims, and which disciplines are you integrating into this advisory committee? I would be very interested in that. Thank you.
Should I come up? Okay. Thank you so much for that question. It's a wonderful question. So the main purpose is we have recognized that, you know, we do offer a number of programs through NAU that are focused on behavioral and mental health in both clinical psychology, but also social work. We have different programs through the College of Education, through even our criminal justice programs, in nursing, you know, so we have a broad array of programs, but we want to ensure that our programs are really meeting the needs for the workforce. So the main point of forming the committee is to bring in community partners actually from around the state to get your perspectives and input on how do we best enhance and develop and strengthen our programs to really help produce and train a workforce that will be able to accomplish and address these behavioral health and mental health concerns. So we want to ensure that we do it with cultural humility and cultural competence, but also what are the other skills and competencies that are most needed to address the concerns we have. So that's why we want input, and we'd love to have additional members join the committee. We just started meeting, so please let me know if you'd like to be a part of it.
Any other questions for the panel?
Also, my question for Dr. Baldwin and also Dr. Zabit. And I would congratulate you, Dr. Baldwin, and all the success that NAU has had and the efforts. We've heard a lot about it, and we really appreciate all of your efforts and recognize your successes. So thank you for that. My questions are for the higher education institutions that are here. Is what's taking place in terms of tracking students that graduate and go into the field? What are the standards, or what's taking place is either at the university level or in terms of tracking students? We better understand where they're actually going to practice.
I wouldn't say we track them, you know, on an individual basis in terms of progression of their career and so on and so forth. What we do know is that we're getting more applicants from our local region to our programs, which is really an indicant to us that we're really doing a better job of promoting allied health education, certainly in Yuma and the surrounding region. So, and we've expanded the number of individuals that we take into our program. So we know we're increasing the number of healthcare personnel, particularly in the nursing area. And we know that now we have more applicants from our local region than we can handle. If you go back 4 years ago, that wasn't the case. You know, our applicants came from all over. Part of the problem with that is that when they finish the program, they go back to where they came from. But now that we're getting local applicants, we do know that a lot more of them are staying here in the community and, you know, filling positions that we need here to address the kinds of health issues that we want. But I don't think we have a good tracking system in place. It'd be nice if we did that. I don't even think our alumni association does a really good job on that as well. So we have a lot of room to move there and improve. Julie?
I would just add that I've been in this role for a pretty short time, but I think one of the things that's become clear is the importance of coordinating all of these activities too. And so we do have someone at NAU currently in the Flagstaff office. Her name is Kimberly Frick, who's also monitoring and coordinating internships and clinical placements. And I think that's going to become very important. And it's really critical that we do that because there's a gap. There are not as many clinical placements as we currently need, and we're going to have to develop those more too with our healthcare agencies around the state. And so I think that very topic in terms of tracking, not only in terms of placements, but once people graduate is going to become critical. And I'm hoping that we can identify one person or a couple of people at the institution who can really be responsible for that.
Any other questions? Okay. We're going to move on to our next panel. Workforce Development and Rural Communities panel. Please help me welcome Dr. Ed Paul. Dr. Ed Paul is a clinical associate professor of family and community medicine at the University of Arizona College of Medicine and at the Creighton University School of Medicine in Phoenix. Dr. Paul has been active full-time in academic family medicine in both rural and urban settings for most of his career. He has been closely linked with AHEC programs in Pennsylvania and in Arizona, and has been committed to developing teaching skills of rural preceptors, as well as studying and promoting primary care workforce development. Dr. Paul is a former physician member of the Arizona Medical Board, and he has been a leader and advocate in primary care for many years with the Arizona Academy of Family Physicians. Dr. Paul is currently co-director of the Arizona AHEC GME Development Program, which serves to support new primary care residency program startups in rural and underserved Arizona sites. Please welcome Dr. Ed Paul.
Thank you, Alex. It's great to be here. I'm going to bring this up a little bit. Maybe. That looks good. It's great to be here, and I just want to thank Amanda and the planning committee for inviting me to talk about the physician workforce primarily, which we've been working at pretty steadily for the last year and a half, looking at rural communities around Arizona. My experience locally, I need to mention, was spearheaded by Amanda also back in 2010 when I was on the AHEC commission, and she promoted funding to allow me to work at the Yuma Regional Hospital at the time to develop the first family medicine residency program in the county, which we did. Now has gone from 4 residents per year to 9 residents per year, and then this year they are recruiting 12 residents per year, and we'll be graduating 12 family medicine docs every year for this county, which is wonderful. And so Amanda's not here, but she knows all about that, and I greatly appreciate that. So my plan for the next few minutes is to talk about my work through Arizona AHEC with a fellow named Charlie Alfaro, who's here today too, who is a leader in rural health and community partnerships from New Mexico, actually based out of Silver City. And I could talk a long time about what he's done with community health centers and education in those communities. Also an expert in financing residency training programs, which is not an easy topic to understand. And so the two of us have been working together in the last year and a half, looking at rural sites around the state that might be prime for developing new primary care residency programs, something we direly need in the state. So, and at the end, maybe look toward the future as to what we're planning for this. So we need some primary care physicians. I think we know that. And to build on Julie's data, this comes from Dan Dirksen at the Rural Health Center at U of A. And this is a couple years old, but I don't think it has significantly changed. And that's looking at numbers such as 667 primary care physicians currently short in the state, based on the per 100,000 population. Our state ranks 31st in total active physicians. And at the same time, we're one of the fastest growing states in the US. And so my guess is these numbers, if not the same, are a little worse in the last couple of years as our state has grown. Primary care in rural areas is, of course, a more dire need and a bigger issue, and something I've been exposed to for many years, actually. I put together this slide back in January that shows for family medicine, I'm a family physician. There are other primary care physicians, of course, that we need in our state, pediatricians. Some general internal medicine physicians, there aren't a lot of those. I'm interested going into primary care. So, but mostly it's family medicine when we talk about primary care. And this is a list of the 17 programs currently in the state that are accredited. Most of these, of course, in cities in Tucson and Phoenix. I made a note there in yellow, which ones are community health center based, which is not a lot. And that total is something like 110 slots every year in the match, looking for medical students to come into these programs to fill them up. Okay. I won't go into the match process. It's complicated and it's a institutional thing that all programs abide by. But I want to talk a little bit more about that later, about how disappointing the match results were this year. At the footnote, looking back in 2003, we had 6 residency programs in family medicine in Arizona. In 2010, we had 8. So we have made significant strides in the last 10 years. And our goal through my work with Charlie and AHEC is to really our goal is over the next 5 years, at least 50 more slots in new slots in the state for family medicine, primary care in general. Looking at some of the work we've been doing recently, these are new programs, startups in Arizona funded through the state. A bill came through in 2023 that allowed appropriated $5 million for the work that we're doing now through AHEC to develop more rural primary care slots. Most notably on this list is the third down on the left is the Regional Center for Border Health at this site was just accredited, and they just filled their first 2 slots as a brand new program. The other thing to note on this slide is that the majority of these are community health center based, rural health clinic based. We have our first tribal site that is developing in Sackatoon through Gila River Healthcare. They don't have an accredited program yet, but are submitting their application for a small program, either 2 residents or 4 residents per year. And other community health centers around the state you may be familiar with. Mariposa down in Nogales is a great site for a program, as is Sun Life and Casa Grande, et cetera. Maritza is here from North Country, and we together helped develop the first family med program up in Flagstaff back, 5 years ago, 2020. Also, psychiatry is now underway in development at North Country for a program there, as are a few other programs in psychiatry around the state, which is also a much needed specialty in our state. So my role through AHEC is, again, trying to support these programs with Charlie's help, going around. We're not developing these programs. We're acting as advisors and supporting people on how to start a program, how to get it accredited. What about the financial commitments for doing a family med program? It is not something that happens quickly, and just reality orientation for all the different sites that we plan to target going forwards. But we're very proud of this work, and again, I think San Luis and Amanda, the work they've done has been remarkable. And I don't know, maybe 2 or 3 years from now, 6 residents per year. I don't know, going from 2. Graduate medical education programs, looking in general at this map. And if you can see the little dots on there, but most of those programs are course based in Phoenix and Tucson. And this was accredited programs through 2023. This came through Dan Dirkson's office as well. And looking ahead, I think I'll go to the next version, which looks at GME and progress on the green markers on the map. And those programs that were accredited in 2004 are marked in blue. So a lot of region to conquer in rural Arizona, of course, and it's been great fun and very rewarding over the past year and a half to do this. New programs, for those not familiar with residency startups, 2 to 3 year timeline before first residents are on site. 2 to 3, it should say, first residents on site. Once you're accredited, first of all, accreditation takes a few years. Then to recruit residents to your site, another 3 years until the first resident class graduates. So it's not a quick fix to look at those 600 vacancies in the state for primary care, but we have to start somewhere, and we see this as building from year to year as we go forward. The upfront costs, somewhere around $1 million is what we estimate, give or take a couple $100,000. And That money's often hard to come by for small community health centers, such as in Mariposa, Green Valley, the ones that we've been talking to. Reimbursement from the federal government only starts after accreditation is received, which takes again a couple of years to get there. And who knows what the future for federal GME policy is as we stand here today, but it's a big target, $18 billion right now through the federal government supports residency training in all specialties across the US. And so our hope is that money is protected and even increased, of course, given the need for primary care. And that's the investment side of this from the financial side. Teaching health center GME is a term used that looks specifically at community health centers who start residency training programs. Historically, there was startup money available through the federal government, and this ended a few years ago. But currently, operational funding, I call it operational funding, to support programs in community health centers exists through the federal government, and that's at the level I mentioned there, $160,000 per resident. The actual cost of training a resident is estimated to be closer to $200,000, $220,000 a year. So it's not an inexpensive process. And this, again, I think it's on a 4-year cycle for teaching health center money. So this was not guaranteed money. The reapplication process happens every 4 years. So as Charlie and I have gone around the state, we're looking at opportunities as to where we can help programs develop. Some of the numbers here are some of our targets. 17 federally designated critical access hospitals in the state and rural communities. 26 community health center systems that operate 185 sites. 55 rural health centers, clinics, 32 of those associated with community critical access hospitals and 23 independent. And then IHS sites and 28 tribal operated sites. Again, I mentioned Sackatoon is the first one that we've been helping to get their program started. We think there are others available, interested, and that we're going to help support going forward. So the process of filling a residency program, once you have it accredited, goes through a process called the match, which I can't go into detail on the time I have, but it's a process that every family med program, every residency program in all specialties mostly adhere to or participate in, where it's meant to be a fair and equitable process where applicants, that is medical students, apply to say 10 residency programs in their specialty of choice, and then programs interview anywhere from 20 to 120 candidates to fill their slots. So in Flagstaff, most recently, or at Creighton, where I am, it's usually like a 10-to-1 ratio. So if I have 6 open slots, I'm going to interview 60 people, hoping I'm going to match with those people on match day, which happens in mid-March every year. So it's kind of a convoluted process, but the concept is to keep it equitable and fair for both programs and applicants. This year, we're very disappointing when we looked at family medicine. The interest in family medicine from medical students has actually tapered in the last couple of years and may be going down a bit nationally, which is a little disheartening. The match rate for us in Arizona was 10% lower than the match rate or the fill rate for the United States in family medicine. So it makes us all scratch our heads wondering what's going on here? Why aren't students more interested in primary care? Why am I out there developing new residency slots when we can't fill the ones that we currently have? And there's good answers to those questions, but it's kind of a disturbing time right now. And it led to a meeting of getting all the program directors together here in the last few weeks to talk about the match results in family medicine. And I came up with some ideas and concepts, which I'll share with you, but I still remain hopeful as to what the future brings for family med. This is I don't know if you can see that graph, but the number of positions is the very top line in black. That's the number of available positions for family medicine in the match up through this year. The last dot is 2025 on the right. And the number filled is the blue line just under that, which you can see has plateaued, right? And so other programs in the country are developing new residency programs. We've had a couple hundred new slots over the last year. So that number is going to continue to grow, especially as we do work in Arizona. How do we change that trajectory of the blue line for medical student interest in the specialty and primary care in general is really a key question for us as we try and do this work. I think the need for primary care is not going to plateau or go away. The geographic maldistribution of physician workforce, but the workforce in general is not going to change. How do we address that given the medical student interest in primary care? Good question. Arizona med school graduates, here's who's coming out of med schools in Arizona. And I just looked at a target date of 2013. We had something like 530 graduates from our med schools in the state at that point. Jump ahead to 2030, including what's happening at NAU. I'm estimating 100 students per year coming out of there. I don't know what the actual numbers will be. ASU is developing their new medical school as well. Some of these numbers will expand. I believe Phoenix and Tucson U of A programs will expand their numbers beyond well before 2030. But we're looking at close to 1,000 medical students roughly coming out of med schools in Arizona in 2030. We're training med students currently to go out of state is the issue. So those students, the majority don't stay in the state to fill residency training spots. And so we're training them and they're leaving. And so we're a farm team, somebody was saying a few weeks ago, as in baseball, to train people to go other places. And so that's the impetus for developing new GME or residency training slots. Sorry, I'm moving away from the mic. For our state is to really try and make a difference. Some of the other factors that relate to family medicine, at least particularly, and this is a general consensus from the meeting and from the national organizations in family medicine. Primary care residency training declining interest is attributed to several factors: lower compensation compared to other specialties, high workload and burnout for primary care, perceived lack of prestige compared to other subspecialties. Increasing student debt. It's not unusual to hear medical students have debt of $500,000 to $750,000 coming out of med school. So that drives graduates, we know, toward higher paying specialties. Dermatology is very popular these days. Radiology, emergency medicine, et cetera, have no problems filling on match day. And we think the monetary side of this is very significant. And I would add, and all of the program directors would add that we just got together, that we don't do a very good job at exposing medical students, at least, to primary care once they enter medical school. Many of them come into medical school interested in primary care. We don't have, this is a general statement, enough role models of family physicians, general internists, general pediatricians to get those students excited about the specialties and to maintain that excitement until they graduate and then choose a specialty. Subspecialists, a lot more role models in medical schools for students to meet and to follow. And so we think that's a significant factor in kind of changing that trend. All of these things, I think, add up to that. This is what it's all about. And I could talk for a couple hours about this slide that most of us in the room are aware of. And this is I talk to med students about this at every moment I can and talk about the key elements of primary care. We're first contact often for people, whether they're in crisis or for preventive care. Continuity is a gigantic issue as opposed to the typical fragmented care that patients receive all over the state and all over the country. Drugstore clinics, grocery stores, et cetera. Some of that's wonderful in terms of access to care, but continuity of care, getting to know a patient, of course, over the course of time makes a huge difference when it comes to cost of care, minimizing cost of care, higher quality of care, taking just better care of people. Comprehensive with team approach to people is huge in primary care, with coordination by a team, and relationship-centered or person-centered care is, of course, the way to go. and it's critical and really getting to know people and connecting with patients and doing the right thing for them in a cost-effective way. And so students don't understand this. I can tell you, medical students. And if they spend a few weeks with me in my clinic, they maybe start to understand a little bit about this, but they don't really experience the continuity side of getting to know people and taking care of them. And so we need to work on all of that, I believe. The pipeline has been mentioned in primary care. Several people have mentioned local residents and tracking data, I think was just mentioned. We do a terrible job at that in medicine, also in medical schools and residencies. We just had a 50-year reunion for my residency program. It used to be at St. Joe's Hospital in Phoenix. It's now the Creighton program at a community health center. And we had very little information for over 50 years where those graduates were. We had, email addresses from 10 years ago, telephone numbers from 15 years ago. We do a terrible job of tracking. And the significance of this is, gosh, when we have a student come to San Luis or go to Flagstaff and do a few weeks or a few months of training in their career at those sites, we don't really keep track of where they go or if that experience made a difference in their choice of residency training or future career path. We don't really have that information. We need more medical school, high school programs. That's not a standardized thing across health professions. Core curricula, as I said, in primary care in allopathic schools at least is really needs a lot of work in general. And looming student debt, as I mentioned, is a big factor of specialty choice. That's been shown. I won't go through this slide, but the national organizations, this is from, I believe, through the AEFP, the American Academy of Family Physicians, has some ideas on how to get more students engaged and interested in primary care, family medicine specifically. The longitudinal one-on-one mentorship that Jonathan Kartsonis has been pushing a lot through U of A College of Medicine Phoenix is, I think, a real key element, and especially for rural programs and getting students to rural sites longitudinally, allowing them to understand the community and the culture of that site, and then hopefully matching with those students in the match would be ideal. I know Kevin and Amanda are working on a model to kind of make sure that that avenue is open, where once we get to know a student, we can reach out and make sure that they come to this program or to the program that hosted them in the match, and not leave it up to grabs as to where they go. We'd like, family physician salaries to go up by 30 or 40% if somebody could make that happen. And medical schools are, again, key for this, I think, in terms of looking at primary care curriculum and really getting students excited about it. I don't want to ramp too long. So this is a page from the match in terms of exception criteria that look at exceptions to how we could get students into programs, whether it's rural scholars programs, accelerated programs. What is currently being done in other states is to shorten the medical school curriculum to 3 years, and then have primary care residents go into a 3-year residency program, so 6 years total instead of 7 years total. That has been successful at many places around the country, including Penn State University, where I used to work. And U of A College of Medicine Phoenix is working on that actively. So there is, I think, there are ways through the match, I think, to make this happen and to try and grab those students who really, especially local students who do experiences in rural places, to really keep them at that site for residency training. Some opportunities. This is a recent foundation that has given millions of dollars to help GME development in Arizona, specifically rural areas, primary care specifically. It is not federal in any way, so this is protected money. We feel it's private foundation money that's not going to go away. And I'll be working with a team from U of A College of Medicine Phoenix under AHEC on this going forward to continue the same work to look at rural sites, tribal sites, community health centers. This money will go through our 6 regional Arizona AHEC centers to kind of funnel to rural areas. And we're planning for the first time to get at least primary care residency people together in under a consortium or the same umbrella to talk about problems, share ideas and suggestions. And those meetings actually have already started, and I'm proud to be a part of that team that's developing that. So a lot of great things coming up. We have money to really make some of these things happen, which is wonderful. There's also a bill going through the state legislature. I don't know the status of it, to add money also for GME development. We hope that comes through as well. So we have the Arizona AHEC team implementing that grant with 4 other grant recipients in the state that we'll be connecting with to kind of push the same goals and mission. There's also a thing called a residency learning collaborative that just started in family medicine, specifically to share didactic information, lectures between programs, by way of Zoom, didactic content, policies, et cetera, which is exciting part of that. And an academic council, which includes department chairs and medical school leaders to get together to talk about family medicine initiatives. So a lot happening behind the scenes, much of it in response to this disappointing match and the challenge of how do we get more medical students interested in primary care and to keep them interested. I'll stop there. I'm happy to connect with anyone. And as this work continues again around the state for the years ahead, I'm happy to talk with any site or anyone interested in GME development. It's been a lot of fun. I'll stop there. Thank you.
Thank you, Dr. Paul. Our next speaker, Catherine Katie Tucker Ortiz Pino, is a program director for the Participatory Evaluation Institute, part of the Center for Participatory Prevention, Evaluation and Action Research, CHER, at the University of Arizona. She has 12 years of experience in health promotion planning and evaluation with communities in Africa, Central and South America, and Southern Arizona. Since 2017, she has worked as a participatory evaluator and researcher on a variety of projects in Southern Arizona, particularly along the US-Mexico border. She has been working closely with CHWs as an ally to support workforce development initiatives since 2017. Please welcome Catherine Tucker Ortiz Pino.
Hi, everyone. Good morning. Thank you for having me. Today, I have the privilege of talking about the community health worker workforce in rural Arizona. And I just want to start by mentioning that I'm going to talk about a sliver of work that's being done by a wide variety of organizations and advocates and community health workers across the state to support and uplift this important workforce. Oh, there we go. Who here by show of hands is familiar with community health workers? Okay, so I don't have to tell you how important they are and how much great work they do in our communities. I do want to mention that community health workers are frontline public health workers. They help to liaise between some of our most vulnerable communities and health and social services. They help to reduce health disparities. They're one of our most effective tools in workforces to support health equity in our communities. They have a trusting relationship that allows them to really link services, make services more accessible, more culturally responsive. And they really help to make sure that community members have access to those services. They go by many names. So there's community health workers, community health representatives in our tribal communities, promotores de salud, health educators, health navigators. Anyone else have a name that they go by here for community health workers? There's many. Care coordinators. Care coordinators, there we go. Family care coordinators. Yeah, so many different names, many different titles, but they all work under this umbrella of linking communities to care. How many community health workers do we have in the room? I'm gonna take a cue from our stand up. I want to give you all a round of applause. Yeah. A few community health attorneys. Take a cue from one of our first presenters. And how about everyone who works with community health workers? Take a moment to stand up, get the blood moving. Everyone who works with community health workers in a variety of ways. Okay. Wonderful. So one of the challenges we have with community health workers in Arizona, with all of these titles that they use and all the different ways they work with communities, is that we don't really know how many CHWs are working in Arizona. And when I say CHWs, just I'm meaning that whole umbrella of terms that is used to reference the community health worker workforce. And we need to have this information because it helps us to understand the strengths and needs of the CHW workforce, where they are, what they need. It helps identify gaps. So where are there not enough community health workers to fulfill the need of the communities in especially rural Arizona? It allows us to connect and collaborate between community health workers and organizations, and share information and resources effectively. Knowing where CHWs are and where they're working allows us to advocate for them and ultimately improve community health outcomes. And so about a year ago, we finished a community health worker enumeration, trying to answer that question of where are community health workers, where are they working, where are they not working. It was a collaborative effort between the Arizona Department of Health Services, the Arizona Community Health Workers Association, and our team at the University of Arizona to create an inventory of organizations in Arizona that hire community health workers. And we attempted to kind of find them, figure out how many community health workers they work with. Oh, and I forgot to mention that many community health workers are volunteers, so they may not be paid, but they are doing important work for their community as well. So we made sure that they were counted in this enumeration as well. And this allowed us to obtain an incomplete, but the best information we have so far to date, census of community health workers. We do have, and I hope that these slides will be shared after the meeting because I have a lot of links in here that I hope you'll be able to follow later. But we have the results on our website, the azprc.arizona.edu. And it's all in a spreadsheet that shows kind of the organizations and where CHWs are working in the state based on the information we were able to gather in this process. In July 2024, based on this count, which we know is incomplete, there were 1,423 community health workers in Arizona. Maricopa County had by far the most community health workers, not surprising. Around 63 organizations and 674 community health workers are working in Maricopa County. Yuma County was the next, 27 organizations and 185 community health workers. Graham and Greenlee County did not have CHWs that we were able to find. So that is something that is important to keep in mind. In the Western Arizona AHEC, which covers 23,000 square miles, La Paz, Mojave, Yuma, there are around 92 community health workers. So if someone can do that math, not me, that's a lot of square miles per community health worker. Around 26 in La Paz, 11 in Mojave, and 55 in Yuma. And of the Arizona counties where more than 50% of the population lives in rural areas, there were 15 organizations and 170 community health workers. So again, Graham and Greenlee had no CHWs that we were able to find. Apache had 19, Navajo had 102, and many of those in Navajo County are community health representatives working in tribal communities, and Santa Cruz County had 49. Again, we know that our information is incorrect. If something is in here, you're like, I know that there are community health workers in Community County, please follow this link and help us update that information. We're trying to keep this a really dynamic and iterative process because we know that this number is changing all the time. So we do have a way to try to update this enumeration, and we'd love to hear from you if you know of community health workers who work in these organizations. I want to take a good amount of time today to talk about the efforts that are happening across many different organizations and individuals to advocate for the CHW workforce in Arizona. We know that CHWs are an important link in our health system. They help to reduce health disparities. They help to support health equity. They connect people to care, but they don't always get the recognition and support that they deserve as they are working in their communities. And so there are many different organizations that are trying to change this and trying to support them and make sure that they are recognized, compensated, supported, trained in their role. So we'll start with the Arizona Community Health Workers Association located here in Yuma. ASCHOW is the state voice for CHWs. They provide training, they provide support. They have a lot of programs to encourage community health workers. And one of the programs that they have right now is the Rural Arizona Community Health Worker Network, or RAS-CHOW, that meets monthly, and it really brings organizations in rural areas that work with CHWs throughout the state together to share resources, information, training, that sort of thing. They're very active, and it's a great way to get involved in those networks. I know we have many colleagues here from Mexico, and we also have a binational network that is one of the efforts we have at the University of Arizona, and that is meant to try to bridge, our health workers on both sides of the border. There's usually an annual meeting that it was in person last year, right? Yeah, we're back to in person. It's usually in Nogales or somewhere similar in Nogales, Sonora. And this binational network is a way to connect health workers and people in the health professions across the border region. And then the Arizona Advisory Council of Indian Healthcare, AACIHC, does a lot of work with community health representatives. They help to support a community health representative movement. They have many different trainings and support for community health representatives, and that are also applicable to community health workers in rural areas, throughout the state, trainings, policy, and that sort of thing. So I hope that you will be able to connect with some of these organizations and work with them to support the community health worker workforce. ADHS voluntary certification. This was a big advocacy and policy win for the community health worker workforce. It went into effect in 2022. So we are just coming up on 2 years of voluntary certification being active in Arizona. It's recognition by the Arizona Department of Health Services that a community health worker is able to implement the core competencies of their profession. There are over 550 community health workers with voluntary certification in Arizona right now. Of those CHWs who stood up earlier, how many of you have your voluntary certification? Show of hands. Great, yeah. So it's really a way to recognize the workforce and to make sure that there is that support on a state level as well. We do have frequently asked questions. There was a lot of confusion around the voluntary certification process when it first came out. So we have frequently asked questions in English and Spanish to help you get through the process. And for those who were in the first wave of those who were certified in 2022, you're probably coming up for recertification here in the next couple of months. And there's information there to help you navigate that process as well. There's a link here for the ADHS voluntary certification portal that has, again, these frequently asked questions. It has resources, contact information for people who can help you navigate that process. Access reimbursement. This was another big policy win that went along with voluntary certification. So as of April of 2023, certified community health workers that are employed by Access Register providers can bill for reimbursable services. And there are 2 pathways for this to happen. One is to reimburse services through an Access Register provider. So that would be, a clinic or a health provider. And the pathway 2 is to reimburse services through a CHW or CHR community-based organization. And that is kind of a new pathway that's being developed that is hopefully paving the way for community-based organizations, nonprofits, to be able to take advantage of these of reimbursement for services. However, there have been many issues with access reimbursement. It has not yet really been successful. I think there's maybe 1 or 2 organizations that have successfully billed for community health worker services. And so there are many people who are working to change that. And part of it will probably have to be going back to Access to ask for a higher reimbursement rate because the math just don't work out for a lot of these reimbursement activities. But there is kind of this concerted effort to help support organizations to be able to access this reimbursement, and on the health payer side to help make it more accessible to organizations to ensure that they can effectively bill for services. I do also want to mention that community health workers, I think, are uniquely vulnerable right now, as we're seeing many grants being cut, terminated unexpectedly. Many CHWs are supported by grant funding. Much of that funding is federal. And so access reimbursement kind of takes on a whole different dimension when we're talking about the sustainability of the workforce and how we can ensure that CHWs have the funding and the support they need to continue their important work. And unfortunately, we are just not there yet. And so if anyone here does have information about access reimbursement, or if you've been able to successfully bill, if you're helping to navigate the process, we want to connect you to some of those resources. Access has some frequently asked questions. Also, we have some upcoming meetings that hopefully you'll be able to join if you want to talk more about this. The Community Health Worker Workforce Coalition is a network of organizations supporting community health worker workforce development and sustainability. It includes community health workers, nonprofits, clinics, health departments, ADHS access, all the different players in the CHW realm. And we have quarterly meetings the last Friday of every third month from 10 to 12 over Zoom. Interpretation is generally available in English and Spanish so that we can make it accessible to a wide variety of audiences. Our next meeting is April 25th. So that's next Friday from 10 to 12. If you follow this link, you'll join the listserv, you'll get information, you'll get updates of the agenda. And this is really a space where we talk about issues such as access reimbursement and voluntary certification. We understand what's going on with CHWs throughout the state, and we help to provide training, resources, information to support people as they help to develop their CHW workforce. I do, and I can't believe I forgot to put this in a slide, but there are also many smaller CHW coalitions that are led by community health workers in smaller communities. And there is a Yuma CHW coalition. And so let's see, Isabel, Feli, Irene. So maybe you could raise your hand if anyone wants to connect to some of those efforts. Please talk to me. I can help to connect you, or talk to Feli back there, Irene, because they meet regularly, and the local Yuma coalition really helped community health workers in Yuma County to access voluntary certification, to get trainings, to get information, to network together. And there are other smaller local coalitions, not smaller, local coalitions in rural areas that are helping to support that connection as well. Okay. So thank you very much. I'm happy to answer questions. I'm happy to give you my card to connect you to any of these efforts. And appreciate your time.
Thank you. Our next panelist, Maritza Martinique, is the Education Director at North Country Healthcare, based in Flagstaff, Arizona. She provides administrative oversight for North Country's embedded Area Health Education Center, the Colorado Plateau Center for Health Professions, the Northern Arizona Partner Site for ATSU School of Osteopathic Medicine in Arizona, and the Narba Institute Family and Community Medicine Residency Program, and the Psychiatry Residency Program that's in development. She is the Associate Designated Institutional Official, DIO, for the Graduate Medical Education, and leads North Country's Teaching Health Center initiatives, and is a member of the organization's leadership team. Maritza recently joined the American Association of Teaching Health Centers Board Executive Committee as its finance chair. Maritza completed her Master of Public Health in Public Health Practice at the University of Arizona Mel and Enid Zuckerman College of Public Health, and has over 15 years of experience in development, implementation, and evaluation of nonprofit community health programs. In her spare time, she enjoys reading sci-fi, fantasy, mountain biking, and going on family adventures. Welcome.
Well, thank you for this great forum. It's great to hear from so many connected and experienced folks in this world. And I'm excited to be in the same panel with Dr. Paul. We launched the family medicine residency at North Country together, and he, gave kind of a broad overview of graduate medical education, and I'm excited to give more of a granular view. So the Colorado Plateau Center for Health Professions is the Northern Arizona Area Health Education Center, and or AHEC. And I think many in the room are familiar with AHECs. Of course, Regional Center for Border Health is also an AHEC. And all AHECs, this is what we do. We build the rural and underserved health workforce. Our mission at CPCHP is really focused on Northern Arizona, but it's similar across the state and across the nation. And so we've talked a lot about health workforce shortages and how those are concentrated in rural communities and underserved communities. And we really focus on two primary ways of filling those shortages. The first is recruiting youth from those communities to choose a health career and supporting them to succeed in that health career, because we know that they're more likely to want to return either to their home community or a similar type of community and to serve the people who they grew up with in their communities when they complete their training. And then the second way is that the more training someone does in a community-based setting, in a rural area, at a community health center, at in a border community, the more likely they are to want to choose that type of setting to practice when they graduate. So these are the two prongs of the AHEC model. I like to give just a quick history because our organization, similar to Regional Center for Border Health, has a really long history of teaching. And I think that has positioned us to be able to present kind of a grassroots approach to teaching. So our AHEC was founded in 1987, and then there was a local free clinic in town that actually submitted its application to become the first community health center, first federally qualified health center in Northern Arizona. And we did that under the 501c3 nonprofit of NAHEC. So that education mission has been part of our clinical organization since before we were seeing patients. And we really do embrace being a teaching health center and integrate that into our everyday work. And then our AHEC is the green one on the map. So we serve Navajo, Apache, Coconino, and most of Yavapai counties. And of course, there are 6 AHECs in the state. So North Country is a federally qualified health center. So we're a nonprofit. We provide comprehensive primary care, including OB/GYN. We have integrated behavioral health in all of our sites. We have 11 different communities across Northern Arizona where we provide those primary care services from Lake Havasu to Springerville. We also we operate the clinic at the Grand Canyon National Park, and then also all the way down to Payson. So really broad region that we serve. We have a 340B pharmacy to provide affordable medications to our patients. We have a variety of grant-funded community health programs to serve different populations. And then, of course, we have the embedded AHEC. So a lot going on, and it really creates a really rich training environment for students of all disciplines throughout the organization. We haven't heard a lot about the AHECs yet. I know you can't read this. This is just it's just a pretty picture. We rebranded recently, and we really leaned into the beautiful Northern Arizona Canyon visual. So this is kind of what the AHECs do. We try to support every step of the health career journey, from youth as young as we start actually in 3rd grade, all the way through continuing education and supporting accredited trainings. That's why I have the disclosure slide. I'm not sure if this was getting accredited, for practicing health professionals. And we do have something each step of the way. And I really want to focus today on the graduate medical education. I'll build a lot on what Dr. Paul talked about. But I just wanted to mention that we do try to touch all of those different steps and try to keep learners and professionals engaged throughout the process, because it really is a lifelong journey. And the more that we can connect with people as they're going on their health career journey, the more that we can bring those folks back to rural and underserved communities to practice. So graduate medical education, when I think about the impact that we've had in the community, we've been in Northern Arizona for over 30 years. And of course, we've made a big difference. We've recruited a lot of people back to the community. We've served a lot of patients. We've filled healthcare needs. But really the one that feels the most impactful is our graduate medical education programs, because you see these young doctors come into your clinic they start seeing patients. Some of them have never been to a community health center before. Many of them have, but those are more likely to choose our program. But some of them haven't, and they really, you just see this transformation, and they really they stay. We've recruited, we've only graduated 3 classes, well, 2.5. We've graduated 2 classes. The third one graduates in June. And we've recruited 4 of those graduates back to work for us. 1 of them in Flagstaff, 2 in Williams, and 1 in the Grand Canyon. And that's the goal. We want these folks to come back, and we can tell by the experience that we're giving them that that's what they want as well. So it's like in front of your eyes to see this transformation. So that's where I wanted to focus today. The other thing that I think is important about graduate medical education when we think about recruiting a rural health workforce is that it's a catalyst for other training. You know, a GME environment, you have physicians who are then, they want to teach. They're teaching medical students. They're teaching, they have a teaching environment in the clinic where you might have medical assistant students, or you might have nurse practitioner students or pharmacy students. It's an integrated clinic. And that GME also provides some administrative support to help with that clinical training. So GME, when we think about kind of the broader workforce needs, can be a catalyst in these communities to build a clinical training environment that supports all disciplines. So just to give a little bit more context for our organization, so we, I mentioned we've been in AHEC since 1987. We launched our first, actually backing up a little bit, 2008. We started being a training site for ATSU SOMA, which is the medical school based in Mesa. We have hosted a cohort of 10 medical students per year since 2008. They're in the process of transitioning to a different model, but we've really gotten a lot out of that program, recruited a lot of those students back to Northern Arizona. We started a 1-year community-based pharmacy residency in 2010. We've recruited back about half of those pharmacy resident graduates. We started the family medicine residency at the Narva Institute, Family and Community Medicine Residency. You can tell that the Narva Institute is a great supporter of health professions education in Northern Arizona, their names on everything. So we started that program in 2020. We are partnering with NYU Langone for an AEGD, which is a general dentistry residency. That's also a 1-year program. And we're planning our psychiatry residency program, which Dr. Paul mentioned. So we're the only, there's a family medicine program in Kingman, and they also have an emergency medicine program that's sponsored by Midwestern University, and Verde Valley Medical Center in Cottonwood also has an internal medicine program that's sponsored by Cottonwood. And then other than that, we're the only GME program north of Phoenix. So there's really nothing in our close region, and it's really important to build this GME because, and Dr. Paul didn't mention this, but I'm not sure how many people are really familiar with the way medical education works. So you do your 4-year bachelor's degree, then you go to medical school, you complete medical school after another 4 years, sometimes 3, and then you have an MD or a DO, but you can't practice independently until you finish your residency. Residency is a minimum of 3 years. And when people are in residency, because they're generally in one place for 3 years, they do things like buy a house, their spouse gets a job, their kids get put in school. They put down roots in the community where they do their residency. So we have to have those residencies in the communities where the shortages exist, because those residents are much more likely to stay within 100 miles of where they completed their residency. So that's why these programs are so important. Well, one of the reasons. Here's some other reasons. So when we look at data, so this shows the outcomes for a teaching health center model like North Country or like our CVH is going to be versus a traditional hospital. So if you train in a teaching health center, you are 3 times as likely to go into primary care. You're twice as likely to serve the underserved. You're 6 times as likely to work in a rural community, and you're 15 times as likely to work for a community health center. And I see these numbers kind of fluctuate depending on where you get them from, but the trends are clear that you're much more likely to meet the needs that we know are there for rural and underserved communities if you practice in a teaching health center. So how do you create this kind of clinical training environment? You know, building a teaching health center, and I'm not just talking about GME here. I think GME is kind of a case study, and as I said, it can be a catalyst. But these are things that are needed for any community-based training program. This is kind of what we've found in our development of clinical training and building clinical training over the last 30 years. So the first thing is really that leadership commitment and having executive support. We've been really lucky at North Country to have a visionary leader in Dr. Ann Newland. You know, she is an internal medicine and pediatric physician. She practiced in the Navajo Reservation for many years. And I would say without her leadership, we would not have a family medicine residency. Even though we had started planning it in 2010, it was really her push to say, we are going to hire someone to be our program director. The previous program director had left, even though we didn't have the money yet. You know, she made the decision to hire that position. Dr. Paul actually was that person. So we brought him on. And she's also been the one to really push our psychiatry residency to say, this is a priority for us. We're going to make it work. And really committing those institutional resources to make it move forward. And then I'm going to talk a little bit more about these in the next slides, but really looking at the broader community and building capacity, both on the funding side and the partnership side. I know that's a strong part of what NAU Health is doing. And then thinking really hard about our faculty and our preceptors, because if we don't have enough practicing clinicians in the community who are willing and able and feel trained enough to teach, that it's very difficult to move a program like this forward. So these are just a few of the partnerships for our graduate medical education programs. And I think the first thing that institutions need when they're thinking about starting is who is going to sponsor the program, who's going to be the accredited body. That's a very, in this type of training, it's a very difficult question. It shouldn't be so difficult, but it is, partly because of the way the environment around graduate medical education is structured. And I think this extends to other programs too. You know, our pharmacy residency, we have the accreditation, but for our dental residency, we don't. And when you are seeking accreditation, it's a lot of administrative work to build all of those things. And it's not straightforward. And it also can affect your eligibility for different types of funding, as our CPH has learned in building their family medicine residency. Then you have to think about who your training partners are going to be. And again, you know, sometimes that can be a bottleneck when you're figuring out who's going to actually teach these learners in the clinic, whether they're graduate or undergraduate learners. Some of the considerations there are, do you have enough patients in a particular population, pediatrics, for example, to meet the needs of that particular experience? Do they have enough experience? How far away are they? Are your learners going to have to drive or stay in a hotel? And how is that going to affect the rest of their learning experience? How can you develop and retain those preceptors? I'll be harping on that a lot. That's a very big challenge for all of our rural and underserved training programs. How can you adapt as things change? I mean, I will, or Dr. Paul remembers this. You know, we submitted our accreditation, we had a whole plan, and then we changed probably 75% of what we said we were going to do because the partners that we had planned on working with, they had turnover in staff, or we realized, oh, actually, that's not going to make sense because it's going to change the number of weeks that our residents are gone, or, oh, wait, we don't actually have the inpatient pediatric volume at the hospital that we thought we had, so we have to send our residents to Phoenix. There's a lot of these questions that come up, and being adaptable is super important. And you can see some of our training partners on here: to the city, Kingman Regional Flagstaff Medical Center, Banner. We send our family medicine residents to Phoenix for their inpatient pediatrics because there's just not enough beds and enough patients in Flagstaff to make sure that those residents are getting the experience they need to be skilled and confident in treating those patients in the community. They have to get those experiences. And I think that's a really big challenge for rural workforce development, because we want our rural clinicians to really be able to see any patient who walks in the door, because you never know what is going to happen in that community, and you need your physicians in that community and other providers in that community to be able to respond to whatever that is. So in order for them to get that experience, unfortunately, they often have to get that experience in an urban area. They can't get it in the rural community because they're not going to see that particular case or type of case enough times to feel confident to handle it on their own. So that means you're having to do this combined training. Some of it's in an urban area, some of it's in a rural area, and that can become like a really complicated puzzle to put together. And then with our teaching health center money, there's a lot of legalese that prevents us from duplicating funding, which in the world of efficiency is understandable, but it really makes it hard for a lot of our programs to manage the reconciliation process and make sure that we're not messing anything up when we're designing our programs. And then of course you do need academic partners. You know, being an independent federally qualified health center or a rural hospital, you might not have access to full text journal articles in whatever topic that your clinicians need to read. And having that access is really important to making sure your residents are getting the highest quality education. In fact, it's a requirement. And so we have a couple of academic partners who have connected us to those resources, as well as faculty development. Then, of course, we have the question of sustainability. How are you going to make this program happen? Dr. Paul shared that it costs about $1 million to launch a program. That's before it's running. And then you have to have money to keep it going. And I think the smaller the program, the greater the overhead costs, because you have some big fixed costs around your program director and your faculty. And you know, sometimes small communities can only sustain a small program, but that means the cost per resident is higher, and finding enough money to support those residents can be a challenge. Dr. Paul talked about the startup funding. A lot of that is your program director. That's the person who's going to design your curriculum and get all of your letters of agreement signed with partners. There's a bunch of different funders. I won't go over this in detail because Dr. Paul covered it. And of course, please reach out to the Arizona AHEC if you would like to see what's available. But there are some federal grants. Unfortunately, I think we can expect fewer cycles of and maybe a longer time until more of those federal grants are opened up. But the AHEC has really been a strong partner for graduate medical education for years. I mean, this funding is new that Charlie and Ed are doing, but we received money from the Arizona AHEC to help get our family medicine program started, and we could not have done it without that money. And then we've also had support from the NARVA Institute. So finding those local partners who can help support that gap cost. So for example, with us, the NARVA Institute helped us in those first 5 years while we were getting up and running, fill in some of the gaps. So we had to hire all of our faculty, but we only had 4 residents. We were only getting enough payments from the federal government for 4 residents. So that really, you know, as we grew, we needed that money to fill in the gap. And then of course, once you have an operational program, the 2 main sources are the teaching health center grants, and then the Center for Medicaid and Medicare and Medicaid services, both funding through Medicare and Medicaid. And that's really complicated, so I'm not going to talk about it here, but you can talk to these guys later and they'll talk your ear off for days and you still will have no idea what they're talking about. So I kind of skipped, I have more slides on this and I just decided to skip right to this one. So when we're looking at faculty and preceptors, so preceptors are really a bottleneck for health professions training. You have to have qualified individuals practicing in the community who are willing to teach, who have time to teach, who have support from their institution to teach, and then also have the training and are skilled preceptors. This data is from a survey that we did internally a couple years ago, and we surveyed all of our clinicians, both those who currently teach and those who do not. And we wanted to figure out what is valuable to the ones who are teaching and what can we provide to the ones who are not teaching to try and convince them that maybe they would like to join the team. And the reason for that is that if we don't have enough people who want to teach, then the ones who do really get overwhelmed, and they end up having lots and lots of students, constantly taking new students, and they get burnt out, and then they're not a sustainable clinician either. So we really want to have as many people engaged in the teaching environment as possible, assuming that they actually want to teach, because if you're trying to pull teeth to get someone to teach, then maybe they're not the right fit, and that's okay. We can let them have their other skills that are also contributing to the clinical environment. But when we look at both current preceptors and non-preceptors, the two top needs are time and money. And I don't think we can get away from this. I think sometimes we try to, explain away like, oh, well, they love teaching, and that's true, but teaching is work. It takes time. Our clinicians, when they have a student with them, if they're going to do a good job teaching that student, they can't just let the student shadow and watch what's happening and then wait and expect them to learn by osmosis how to care for patients. They have to give them the right amount of autonomy to work with that patient, maybe to do a history and physical and then discuss it afterward. And if they're not doing that, the student isn't getting a good experience. The student is coming away, with kind of a general sense of rural health, but they're not prepared to actually move into a residency program. And so the outcomes aren't just good. And if you actually do it the right way, where you're really doing that engaged one-on-one learning, it means the preceptor might not have enough time to do all of their charting during the day. So they have to do it after their shift. So they're working longer, they're working more hours in order to teach. And I don't think we can just let that go. We have to recognize that that is real. And if we're trying to develop our community of preceptors and faculty, we have to either give them protected time, which we have to acknowledge could take away from other incentives that they have. So many of our clinicians get paid by the number of patients they see. So they have something called RVUs, relative value units, that influence how much money they make. So if we're giving them protected time, it can't take away from that calculation. Or we can pay them for teaching directly. And that is something that North Country has done, but it's not, it doesn't offset the loss of that productivity incentive. So I think this is something that our individual institutions can do. So North Country, for example, started doing a teaching incentive many years ago that is not grant funded, where it's agnostic about the type of student. So any clinician in our organization who takes any type of student or a first-year resident gets a stipend by the hour. So basically, if you teach 40 hours a week, you get $250. And the reason we did it where it could be any type of student is we didn't want the preceptors to be saying, oh yes, I'll take a student from this one institution because they're going to pay me $1,000, but I'm not going to take a student from this other institution because they said they can't pay. We had to make that decision internally to kind of even the playing field so that we could decide who are the students we want to accept. Because we really are focusing on students who have an interest in rural and underserved medicine, who want to work in a community health center or a rural health clinic, who believe in primary care, that's their long-term goal. Those are the students we want to bring, not just, student A from the school that'll give us $1,000 versus, student B from the school that pays nothing. And I think these are like tiny changes that we've tried to nudge in building a clinical training environment that supports kind of the broad spectrum of health professions training. But it's not enough. We talked Ed talked a little bit about the challenges in the family medicine match this year, and I'm not going to get too policy wonky because I know there's probably no one in this room who can directly make an impact on this, but those salaries for primary care providers and the reimbursement rates that we get for primary care services really needs to change, because without those changes, we're all kind of having an uphill battle here in building or filling the gaps in the rural health workforce. All right. So I'm happy to answer any questions. And this is my email, and then our website is cpchp.org. You can find out all of our services there.
Thank you. And now we have some time for some questions. My IT colleague will be walking around with the microphone. If you just want to stand, if you have any questions for the panel.
Well, this question is for three speakers. Do you think it's possible your students or colleagues participate in the training in Mexico, like practice, like internships or more than that? Or do you have the laws for immigration for this kind of exchange?
Ed can fill in at the gaps there. I will say this is one challenge we have. So CMS will not pay you. Teaching health centers also will not pay you if your residents are not in US territories. So for example, for our teaching health center grant, we get $160,000 per year per resident. If I send one resident to Mexico for a month, I will not get paid for that month. So that costs my institution about $10,000 to send that resident, because I still have to pay their salary. I still have to pay their benefits. Well, I could not pay their salary, but I'm not gonna. So we have to find other funding, like a foundation or something to help support the offset of those costs. We have a lot of residents who are really interested in global health, and we want to integrate that into our training, but the federal funding will not, you can't get reimbursement for that cost if your resident isn't in the US territory. So that's a big challenge. I don't know if that is what I had. Yeah.
I think it's a great question. My experience in the starting Yuma program at the hospital is that we did do that and send residents across the border. I remember exactly where, to one of the medical schools, and we did joint conferences, so our residents would go across to do that sessions, case presentations with family medicine residents in Mexico. Then we invited them back to Yuma to do the same thing. We tried to get rotations set up at the Women's Health Hospital and other places. And our local hospital, because of probably input from attorneys, will not allow that to happen because of practice insurance, although we build to much a lot of sense. But so we tried hard to do that. I think there is a way to do it. Other places to go. Border health is rich, potentially experiences on both sides of the border. I'm sure there's educational forums. And actually, direct CHER is so different, of course, one side of the border versus the other, primary care. So it's challenging. Some of it's monetary, some of it's legal issues to try to address those hurdles. But I think it's actually very valuable. So.
Thank you. This is for Dr. Paul and Maritza, I think. But I'm wondering, it sounds like it's really a complex problem to recruit primary care physicians into rural and underserved areas. I'm wondering, from your perspective, how effective do you think current strategies are for doing that? And what do you think might work better?
Referring to research strategies. What
No, get moving graduates, physician graduates of primary care into rural and underserved areas, recruiting.
Yeah, it's the thing we did not mention in presenting today were international graduates. You know, when we opened the program in Flagstaff, we had 1,000 applicants for 4 positions. There are about, I'd say 20 of those were US graduates, the rest were international graduates, including from many schools in Mexico, by the way. And that's all wonderful. And the challenge with that as a program director who's relatively naive about medical school curricula, not only in Mexico, but all the Caribbean schools, what about Czechoslovakia, Eastern Bloc countries. There are some really valuable candidates out there to recruit into our programs, but filtering through and finding the correct match is really hard. So You know, your question is, what is the key here? How do we proceed?
What's the secret sauce?
I think I'd start with, as I mentioned, medical school curriculum, trying to get students more enthused, even from, you know, grade school, high school, talk about health professions careers, especially local citizens, for example, from this area who wants to go into Anna's residency, Kevin's residency here. Gosh, we should try and find those people, local folks who can go for training and come back for residency training. The likelihood of those people staying in those communities is very, very high, like 80%, 90%. So I think there are pipeline issues from all levels of education, private and school or health profession schools. Selected recruitment strategies. So once, as I said, once we get to know those students in this program, for example, we have priority in recruiting them for our program and not letting the match process decide where to go, which is very frustrating.
Yeah, I just wanted to add that reminded me. So I mentioned that we recruited 4 of our graduates back, 4 of our family medicine resident graduates. All 4 of those went to Arizona medical schools. And I just realized that a moment ago. 2 of them did medical school training with us in Flagstaff. And then 1 was at Midwestern and 1 was at U of A Tucson. So I think that's kind of the secret sauce is, can we keep them here for the whole pipeline, keep them in Arizona for medical school, keep them in Arizona for residency, match them in a community that they know, that they have built connections to for that whole time. I know that Anna's going to talk about the longitudinal integrated clerkship and how that can work in medical school training to embed someone in a community for a long time. That seems to be the most effective model. However, we know a lot of people, a lot of institutions, a lot of academic institutions want to scale that model, but it's very difficult to scale because of the bottleneck in preceptors. So figuring out how we can build that capacity to scale that model is, I think, the next big thing.
And new medical schools are big problem.
It's a great response.
In the past, students that, or professionals that came to work in rural, high poverty areas were allowed to request that their student loans be forgiven after a particular amount of time. Could you share if this program still exists?
So there are multiple programs, including through HRSA, federally to, as well as the state, to entice graduates to go to medically underserved locations. Multiple options. The latest emails I'm getting are suggesting we're not advertising those opportunities to graduates nearly as much as we. So a lot of those positions aren't funded or go unfilled, and I believe because students just aren't aware to go through their hectic pace of medical school, really understand that's really an option for me to go back to this community. A lot of the debt. I mean, I mentioned 500,000 on the low end. That's debt these days. It's a lot.
I think you're referring to the public service loan forgiveness, and that applies to any profession or any degree. What Ed's talking about is there's the National Health Service Corps. National Health Service Corps does like an annual loan forgiveness. I think it's up to like $50,000 a year, as long as you're training in first of all, you have to enroll as a National Health Service Corps member. So when you're in medical school, you have to say, I'm going to do this thing, and you commit to work in an underserved community for a certain number of years. And while you're working in that community, then you get this loan repayment. It won't forgive your entire debt. You may also be able to do the public service loan forgiveness. I think that that's one of the programs that we can expect to see some targeting at the federal level, because student loan forgiveness is a hot button issue. The other program that I mentioned is the Arizona State Loan Repayment, and it's modeled after the National Health Service Corps. So if you're not a National Health Service Corps member, you can still apply for Arizona State Loan Repayment, and it's the same thing. You have to work in what's called the health profession shortage area, and they have a whole formula for how they decide how much to forgive, but it's a similar dollar amount to National Health Service Corps, but it's state dollars. I think those are the ones, the Arizona State Loan Agreement is where they're not getting that. So there's more money there than is actually being used. They also have some stipulations like North Country can't take all the money. Like if we're really good at promoting it to our providers and they all apply, they won't give it to us. They will only award it to a few people in your institution and then they try to award it to somebody else. So there's definitely a bigger need. I would like to see loan repayment for preceptors. I would like to see us say, if you're a faculty member or you're teaching in a graduate medical education program or.
Are there any more questions for this panel? Yes.
I'm very good. My daughter is a family nurse practitioner, that's family practice. And now when you go to the physician's office, you see the doctor's name and you see nurse practitioners, PA, but you don't see any other doctors because of the shortage. So do you think it's because of the autonomy of the nurse practitioners now that, and it's cheaper, that we see more nurse practitioners? Especially.
Yeah, one obvious part of the answer to that is those providers cost less to hire and employ in my system, right? I don't know the data in terms of the rural workforce for nurse practitioners, PAs, maybe somebody does. Is that going up? Is it plateaued? I don't know where that is. But I think having those teams of providers available was, I think, with a physician involved in the teams. And I think the opportunities are great for nurse practitioners and PAs for rural areas. Just boost their primary care. I don't know if I answered the question, but that's good. That's common. What you described is very common, not only in rural areas, but urban areas, because of the costs that those providers get. Anybody know data on it?
One question that I'm seeing in our community, sorry for the voice, but what I see a lot of promotion in Yuma County is on nurses. A lot of promotion. And when I think about our students who are primarily first-gen students, the task of medical school can seem a mountain that is not able to climb. So I'm wondering if there needs to be additional promotion to become a doctor and not just a nurse in our region. To that point that was just made on the opportunity of here is the pathway that includes financial incentives to get there. Because that's what's kind of needed. I see the opportunity just, I think as you were speaking, I was looking at what programs are out there that come into the high schools or have summer schools. You have Harvard that has one. There's a whole organization that has them. They're pretty pricey though. It's like $1,800 for like summer. But to me, what I see is that in Yuma, we do have programs that support in our high school to be a nurse, but we don't have any that really get to a place of, I want to join this field. So I think there's an opportunity of, to the point of promotion and then knowledge to our students in high school that would be eager to want to stay here.
I have one question. I can't let it go. It's for Catherine Tucker. It's about the community health worker. And I was listening to your presentation. I wasn't aware that the certification was a voluntary certification. Is there another certification for community healthcare workers, a more formal one that is recognized by the state, or is it a matter of their educational impediments and what have you to that certification? So many offer the voluntary certification.
It's a great question. The voluntary certification is through the state. It is through NHS. It's the official licensure for the community health worker workforce. It's voluntary, and that's very purposeful that it's voluntary because community health workers work in a variety of organizations. They work with many different communities. This kind of goes to your question as well around education. They have a wide variety of different training certifications, community college. Sometimes their training is very informal. And so the community health worker, so you are not required to have a certification in order to practice as a community health worker in Arizona. If you want to apply for access reimbursement, it is a requirement to have the voluntary certification. But there are also many community health workers who work with, who are undocumented, who don't have the ability to obtain a volunteer certification. And so it's a very intentional strategy for community health workers to have the certification be voluntary, so that we're not, we're recognizing the importance of the workforce while not barring people from doing the work they've been doing in their communities for many, many years.
Does that certification work with Medicaid for reimbursement?
Yes, yeah, so the certification is for, you have to have the certification for Medicaid reimbursement. There's also Medicare reimbursement, that's also pretty new, that's coming out right now, and you also need to have the voluntary certification for that. But that is the state level certification, but it also, back to your question around the training, CHWs have many different types of training. There isn't a single educational requirement to become a community health worker. Experience can be used in lieu of training, and so many CHWs come from Mexico, from other places. They have training in a variety of different settings, and that is not a barrier to the long-term.
We have time for one more question.
But the first is, as we move on new med schools on the border, we have more med students that are willing to get into these programs, and honestly, most of them are willing to stay in the border because they are where they from. So how potential do you see into build some connections in order to the or med schools, and I'm a director of one of the faculty of medicine in Mexico. So how we can connect them, and in order to show you or start sending you best options that we know how they're going to fit your necessities, and they're going to be a better candidates. And the other question is, how do you address and how important is in your curriculums for your students the clinical simulated scenarios? How much you use it? How much you're using these technologies? Because they're hard maybe sometimes to reach the clinical case we are looking for. And in this scenario, it's really, really hard. So thank you.
Upset with that, I think, the opportunity to develop curricula across the board, I think is fantastic. I don't know how to do that, but I think having a team with that when I was at the hospital in Yuma trying to develop things across the border, I went to meetings and I would man this team across the border occasionally. Boy, it's an opportunity that are wasted. And no, I don't know a good pathway, but there's some legislative input in Arizona and also across the border to allow that to happen. But the potential to build to attract local students to local programs is huge. Simulation curricula in family medicine, primary care is relatively small compared to other specialties like surgery. There was a lot of hands-on work. There's a little of that in family medicine. Most of the simulation with our residents and students exam room settings where we watch them interact with patients and try to make diagnoses, whether it's a senior medicine person, and also focusing on the communication skills during that process. That's so important in primary care. So for us, simulation means mostly relationship or interaction as opposed to some of the more procedure work.
I am a third year DMP student at ASU, and I just wanted to make a statement and say that when I was going through the course of my career, I had a really difficult time finding preceptors in this community, which I can imagine affects in the end the amount of providers that come back to the community. I was wondering if there's an initiative that provides residency programs for APPs or events.
Yes, there are APP residencies. They're not required, as you know, so it's not like a required part of training. Because it's not required, there's not a lot of funding for it. So there are institutions that have their own APP residency. We have found, so we don't have a formal residency, but we do have like an on-the-job, or what we call it, like where you get a little bit more support from a practicing clinician in your first year, because it is a big learning curve to get out into the clinic or into the community as an APP right after graduation and just be seeing patients on your own. So there's a lot of value to APP residencies, particularly for NPs. But the funding or institutions kind of have to build them on their own because there's not a lot of money. There is a HRSA grant similar to the Teaching Health Center grant that's for graduate nursing education. But I don't think that there's a lot of rounds of that funding that have come out. El Rio, for example, does have that grant. So it's a great need, and I agree.
Thank you, everyone, and that's a great discussion that you were having. We encourage you to continue it, exchange business cards, and keep in touch. Moving on to our next panel discussion, Border Research on Border Communities panel. And our first panelist is Ms. Priscilla Ruedas, U of A College of Public Health. Ms. Ruedas is a lifelong U.S.-Mexico border resident from the Southwest and a passionate public health professional dedicated to advancing health equity for marginalized communities in the border region. With a master's in public health from the Melanina Zuckerman College of Public Health at the University of Arizona, Priscilla's work centers on bridging the gap between public health and the community by building strong, trusting relationships with local partners and stakeholders. Priscilla has worked on both sides of the U.S.-Mexico border, addressing key public health challenges such as vaccine hesitancy, healthcare access, and farm worker health. She advocates for policies that reflect the unique needs of border populations, ensuring that public health initiatives are not only community-driven, but also sustainable. Through outreach and collaborative partnerships, Priscilla works to create lasting impacts that directly benefit border communities. Please help me welcome Ms. Priscilla Ruedas.
Hi, everybody. Before we get started, I wanted us to just stand up and stretch because we've been here a long time. Let's do a little movement. We're almost through it. Like 40 more minutes. We can do this. Yeah, you got this. All right. Well, thank you so much for humoring me in that. I do think we need a good little movement there. So thank you again. My name is Priscilla Ruedas. My pronouns are she, her, ella, and I'm here to talk to you all about today on one of the classes that I teach at the College of Public Health. So I titled this, it's Transforming Public Health Education at the U.S.-Mexico Border. So we're going to be talking about the Border Health Learning Service Institute today. And then I just quickly wanted to just introduce a little bit about myself, but I don't have to. That was a long intro that I didn't realize how long it was. But as I was mentioned, I am a proud border person. I used to call myself a border kid, but I'm old now, it doesn't apply. But with that being said, I am proudly from Mexicali originally, and then grew up in Yuma for the majority of my life. And then I went to the U of A as an adult. So my curriculum and my life is really different. And with that being said, I have this really strong love for the US-Mexico border, but for bringing people here and teaching you about how wonderful the US-Mexico border is. It's not what we're hearing in the news, and really trying to learn about how we keep our people here, how we bring new resources to the community, and how we strengthen one another. So with this course is called the Border Health Service Learning Institute. It's a course where we take graduate students, mostly from the College of Public Health, but we do open it up for other health professions. So we have had students from clinical translational sciences, Mexican American studies, and we are open to collaborate as much as we can. And we're talking to students really about the intersection of economics, migration, and health. The NASDAQ came up. Something must have happened. Okay. So, sorry, I wanted to look at my notes. So why Border Health Service Learning? So this is a different method in which we are teaching students. We are not doing the lecture and take notes and then you're going to get quizzed on it. This is an interactive experience where we take students and we are taking them into the community to have hands-on activity. So service learning is a practice-based course so that we can further expose the public health students to the intersections. Again, this focus is economics, migration, and health in the US-Mexico border. But what we're really trying to do is provide the future public health professionals with a deeper context of the US-Mexico border and the impact that the US-Mexico border has, because the impact isn't just happening here locally, the impact is international. The Border Health Service Learning will create a space for critical learning because we're having direct community engagement. And what we really hope that comes out of it is that we're creating some ethical, empathetic public health practitioners that are going to center health equity, especially in historically marginalized regions like the US-Mexico border. So I am going to take, I'm going to take just a second and have us just spend a little bit of time thinking about the US-Mexico border. So this is just an image of the US-Mexico border, and this is 1,954 miles or 3,145 kilometers long. It stretches from the Gulf of Mexico to the Pacific Ocean. It follows the Rio Grande for a significant portion of its length. If we're looking at the US-Mexico border, this is the busiest and most traveled border in the world, and well over $1 billion worth of goods cross every single day. This is a place where two sovereign nations come together, where 4 states in the US, many indigenous nations, and 6 states in Mexico are all meeting. We have a total of 44 counties, 80 municipalities, 14 pairs of sister cities, like where we are right now, San Luis, Arizona, San Luis, Mexico. This is a 100-kilometer region of our border. And if we take everybody that lives in this US-Mexico border here, and we created that and we made that into a state, this would be the poorest state in all of the United States. We would have some of the worst health outcomes, we would have some of the poorest incomes, and we really need to be able to bring some of the resources here and really highlight all of the strengths. So I'm going to talk about the origins of border health. How did this interactive learning model come to be? It's really coming out of the Keeley 2005 transformative learning model for service learning. And this came to be from Doctora Cecilia Rosales and Jill Gernstein de Sapien, who in 2008 came together to kind of address a lot of the things that were happening post SB 1070 with a lot of the US-Mexico border and the community as a whole. And the purpose and the goal of this was to address the health equity in the US-Mexico border, but with really understanding of migration, economics, and health. You can understand the US-Mexico border, but if you've never been here, there's a lot of hearsay that happens if we're listening to the news. Most of the people have never actually been to the US-Mexico border. A lot of the people who are making a lot of policies have never been to the US-Mexico border, much less actually experienced the US-Mexico border. Being here for 10 minutes a day is not the same as some of us who have lived here our entire lives. And so we have a lot to offer to the world. So what is the course? What does it look like? So this is a practice-led course where we're exposing students. What we do is we kind of we have a group of facilitators. We are not instructors, we're not teachers, we are facilitators because we are just facilitating a conversation to happen with the students. We bring in multiple guest lectures, we frame it around these 3 key issues. We bring in people from all of our organizations in the, we bring in folks from all of our organizations that we partner with to really just kind of highlight what it is that they do, how it is the work that they do, and to see where the students, 1, fit in, and also 2, where your perceptions may be different, maybe to see if we could shift any of that perceptions. So we have a lot of CVPR, both the research and activities. We spend time in the community. We are co-learners with both the students, the people that we're working with. And we're centering a lot of ethnographic readings and lectures that are centering the US-Mexico border regarding immigration and migration, public health, Latinx. And then the agriculture and labor, that one will kind of change. Each cohort will kind of take its own kind of phase, but this reason the agriculture and labor was this last one that we just did was really because a lot of the instructors of the class, we just finished a study that was published in October of 2024, where we estimated the numbers of farm workers that exist in the state of Arizona through a mixed method study, but it came down to 79% of all farm workers in the state of Arizona are based out of Yuma County. So that is a huge number. We have a huge workforce here. And so really we were trying to provide some more context regarding that. So what we're really trying to do is we are exposing students for hands-on learning, and we want to be able to bridge that gap between academia and community, because we want students to be able to go into the community and be able to do the work truly. But really it's the same concept, the difference between theory and practice. We all know that reading something and then actually implementing it and doing it is completely different. And once you're able to do that, you can have a lot more of an understanding, a lot more of a buy-in. So this learning model that we have, it will promote critical reflection on border issues. It'll bridge that gap. We cross into Mexico. We are going to cross into Mexico. So for example, this last cohort that we did, we crossed from Douglas into Agua Prieta. We spent the day in Agua Prieta for a Saturday. Then we come into Yuma, and we're in Yuma for about a week, where we meet with all sorts of partners, like here with the Regional Center for Border Health, which we always love to come. We learn so much about all the work, and we're always updated. We meet with the health department. We meet with Border Patrol. And what this really does is it kind of immerses the students into this world. You can't leave it. You're in it and you're experiencing it, and we all come with our own biases, but as you're living through the experiences, we see a big shift in students. So there's obviously two types of students, right? People who self-select into this course, like me, because I'm from the border, I want to see what's happening. And then there's people who are never been from the border, who really want to learn and know about what's happening. And so from people who had never really been to the border, we see a shift from a media field unknown of what the border is to really appreciating the community for the strengths that it is. And students are inspired to serve border communities, to learn Spanish, to focus on rural binational immigrant help, join advocacy groups. I'm really proud to say that this last cohort, there's not too many of us from Yuma, or there's way more of us from Yuma now, but this last cohort, there was 3 out of 15 were Yuma locals. And at the beginning of the class, because I'm a human, I like to talk to people and kind of gauge their interests. And at the beginning of the class, I asked, so what are your plans after graduation? Many of them are graduating this next month or potentially in a year. Oh, well, I'm trying to find a job here in Tucson, or I'm trying to find a job that'll pay me well. Oh, are you interested in coming to Yuma? Like I'm okay at this. I don't really see myself there. Is a lot of the conversations that I had with the students on Monday. When I had a conversation with them on Thursday, after going through this and seeing like how much Yuma has grown, how much the Regional Center for Rural Health, Ms. Amanda Aguirre, like truly has opened the doors for so many new things to be coming into the community. It's really transforming. By the end, all 3 students want to be back in Yuma. One of them's already been connected to Diana. Another one, we're trying to connect them directly here because he was really excited about the San Luis Hospital. And the third one is doing some work with Border Patrol and public health, which will be really interesting to see. So with that, what I'm really saying, what I really want to share here is that there's a way in which we can take the students' experiences and highlight the strengths of the border so that we can show and showcase the work that we're doing, how impactful it is, and really keep the students here, because we really need to be able to keep all of this knowledge all of these folks locally and bring in additional students, right? It's not just the students that are from the community. Then there was also these students that are not from Yuma that are very interested in Yuma because we show them obviously like the best stuff, right? But nonetheless, they are interested in coming into the community. And so we're really hoping that we are bridging these in. We're hoping that we can bridge them with internships with all of our community partners. And so what is the reason that the Border Health Service Learning Institute works is that we are community rooted. We're action oriented. Sometimes when you're in school, like it's all of the lectures, it's, at least in my perspective, that gets tiring. I want to get into the community. I want to be doing something. Like, what is it that you need? I need to be moving past just lectures, Zoom calls, doing readings. I want to get my hands dirty. We are culturally grounded, and we really want to encourage students to find their passion and how it brings them into the community, and how, excuse me, how it fits, whether you choose to come back to a border town or not. Rural health, border health will always follow you wherever you are. So with that, I just want to say thank you to all of our border communities partners, but most importantly, all of our friends. Here's just a couple of pictures from the last border health class that we have here. This one in the middle is us maybe 2 years ago here at the Regional Center for Border Health. And that's all I have for you all today. Brief and short, but I am open to any questions that you may have.
Thank you, Ms. Ruelas. Our next panelist is Ana Montoya. Ana Montoya is the director of the Western Arizona Health Education Center, WAHEC, and a dedicated professional in the field of health science and healthcare management. She earned an associate's in general studies before completing a Bachelor of Science in Health Science and a Master of Science in the Science of Healthcare, all from the Arizona State University. As WAHEC's director, Ana leads initiatives to improve health education and services in Western Arizona, playing a key role in community outreach and healthcare training. Her strong academic background, combined with her leadership in healthcare, allows her to make a meaningful impact in her community, enhancing health access and education across the region. Please welcome Ms. Montoya.
Right, well, good morning, because it's still morning. I just want to first say thank you, Alex, for the introduction. It was beautiful. And thank you, Ms. Amanda, and as well as the planning committee for having us all here. So I know there has been a lot of discussion, a lot of talk about LIC. And I'm pretty sure maybe there's half of you guys around here that might be asking, what is the LIC program? So we're going to talk about it. So the LIC program, it is the Longitudinal Integrated Clerkship program. We do communicate with the College of Medicine of Phoenix. So we work with year 3 medical students who come and thank you. So the introduction to the year 3 LIC clerkship program. So the medical students, like I said, they do come with us for 6 months. They get to experience that rural clerkship that they wouldn't get in a bigger city. For example, the College of Medicine for Phoenix, they send us, right now we have our 3rd cohort coming in June. So we're very excited, especially because as you guys all know, we do have a residency program as well starting in July. So excited. So for now, our 3rd cohorts are going to be coming in June, and we want them, so the LIC program, LIC program. So when we talk about the LIC program, we do really like to implement the program goals during their clerkship here with us. So we do like to train the students to become rural physicians. So they do spend several weeks with different specialties during their time here with us. It's either in San Luis, it's in Somerton. We do want them to get that rural experience that they don't get anywhere else. I believe it was Dr. Ed Paul who had said, and first of all, I really appreciate your presentation. You had stated, how can we get their attention? How can we make them come back? There's a lot of medical students that they do come, they train, and then they leave and they're not able to come back anymore. Or, how can we pique their interest? And with the LIC program, that's what we do here, is we pique their interest in coming back and do their family residency. Now that we do have the first family residency in Somerton, Arizona, in San Luis, Arizona.
that's the start of how can we pique their interest in coming back to a rural place. So the LIC benefits for the year 3 medical students in San Luis Walking Clinic, there are a lot of benefits, especially because they do get to experience all different specialties, all different learning opportunities. We're right next to the border. I remember last cohort, our 3 boys that came over, 3 medical students. They've never gone to Mexico, to the other side of the border. Obviously, we didn't take them, but they did go on their own, and they expressed just how different the culture was, especially from them being in Phoenix. They don't get that culture exposure. So the LIC, so I just want to include some pictures. So we do have our Dr. Samani, she's our family physician. She was the LIC site, LIC director here. As of now, she is the residency director. We're very excited for her. So why is the LIC program crucial for border communities? And I think this is something that I had agreed with you, Dr. Paul, that, you know, it is the first start of grabbing their attention to coming back. Once, just like also something that you had said was exposing, it was need more role models. And I have to agree with that because that actually changed my whole perspective when I was in school, was the preceptor I had that made me fall in love with health education and program development. So it is very important to have a role model medical school. And thank goodness that we do have great communication with Dr. Jonathan Garzones, as well as all the preceptors here. You can tell right away the preceptors here in San Luis Walking Clinic, they have a dedication to teach, to train students everywhere. Even a couple of days ago, I even got students from all the way from Illinois that they heard about Dr. Richards, that they wanted to be with Dr. Richards. So we do get a lot of students from different states wanting to come to this rural community, and that just shows a lot. That shows a lot about how they're willing to drive all across the state to get their clerkship or internship here. So our future goals. For the future goals, right now I am implementing a research project with the LIC program. It is actually the poster that I have down there. It's called Transforming Rural Healthcare, 3rd-year medical students, the LIC program. It is, I believe, Dr. Ed Paul, sorry, I really enjoyed your presentation, so I have a lot of comments, but it was about tracking, about how are we tracking the medical students that, you know, they're done with their clerkship, they leave, do they come back, are they in a different rural community? So that's actually a project that I was talking with Ms. Amanda and Kevin as well, Dr. Jerson, about let's start tracking our LIC students. So my research is after they're done with medical school, I want to track where do they end up going. As well, so the assessments for that project is based on their clerkship experience, their preceptor experience, as well as their, I do want to track, this might be a little bit difficult, but I'm going to do it, is track what their career goal was before they started the LIC program and their career goal after they left with us. So it's kind of seen like, let's say a medical student with the mindset of I'm doing peds or I'm doing surgery. They come and do their LIC experience. They do the family rotations. 6 months later, I get the survey again, and they say, you know what? I really enjoyed family medicine. You know, just being actually, you know, first step in there. I want to pursue family medicine. So that's part of the assessment too. So that's how I'm going to be tracking, because I am really interested to see the LIC students who complete their rural experience here with us. Where do they end up after medical school? Where do they match? Are they pursuing family medicine, or did they pursue something else? What was the factor of them pursuing family medicine? So our future goals for LIC program is to recruit, strengthen, and expand. And that is what we believe, you know, the rural community. Yeah, thank you. Oh, and thank you. And then there's my email if you guys need it. Maybe you guys have any questions. I'm more than willing to answer some during our Q&A. Thank you.
Our next panelist is Dr. Alfredo Padilla Lopez, a psychologist who studies the neuropsychological and psychological basis of behavior, training and professional practice in psychology, and ethics in professional practice. He has contributed to the design and development of projects of the National Council for Teaching and Research in Psychology in Mexico, the National Federation of Colleges, Societies, and Association of Psychologists of Mexico, and the Mexican Society, the Mexican Association of Researchers and Professionals of Organizational Communication. He has also collaborated with psychology professors and researchers from various countries in Latin America, the United States, Europe, Asia, and Australia. He was a member of the Standing Committee on International Affairs of Division 29 of the American Psychological Association. He is currently a member of the BASW Advisory Board of Northern Arizona University, past president of the International Council of Psychology Educators, and a member representing Mexico in the Global Psychology Alliance. Please help me welcome Dr. Alfredo Padilla Lopez.
Well, I only speak in Spanish because my English is so bad and my brain not processing so faster in English. And thanks a lot for the invitation. Thanks a lot. And thanks for me to interchange my ideas and my experiences with you. In this session, I talk about border research, borders community, and workforce development. Y voy a tratar de hablar desde la perspectiva de las universidades, porque es lo que me toca hablar desde la perspectiva de las universidades, un poco con enfoque social, porque es también parte de lo que hago. Y creo que por lo que hemos escuchado hasta ahorita, pues también me toca hablar sobre la psicología, porque no han tocado el tema de la psicología y eso me parece interesante. Bueno, primero, el rol de las universidades a nivel global ha cambiado y está cambiando hacia diferentes enfoques, aún manteniendo algunas cosas tradicionales como la formación profesional, la investigación científica, pero definitivamente las universidades, independientemente del país en el que estén, tienen dos condiciones que nos hacen muy particulares para el desarrollo social y el desarrollo de los servicios de salud. Una es que la educación superior no es obligatoria en ninguna parte del mundo. La educación superior no es lo que sigue de la preparatoria, no es lo que sigue del high school. La educación superior siempre ha sido, y siempre, supongo eso va a tender a ser todavía, es una estrategia de la sociedad, es una estrategia de los estados para el desarrollo socioeconómico, cultural y político de las regiones. Y actualmente de la globalidad. Porque hace rato les preguntaba si era posible hacer este intercambio. Dicen, bueno, hay ciertas reglas, sí, pero acuérdense, por lo menos desde el APA, que me tocó conocer de la American Psychological Association, algo que les estalló así en la mesa fue la telepsicología. Las barreras, las fronteras se eliminaron en los servicios clínicos. Entonces, tener experiencia de lo que sucede en otros países y cómo lo hacen siempre es importante. Entonces, les decía dos cosas sobre la educación superior. Una, es una estrategia de desarrollo profesional, es una estrategia de desarrollo socioeconómico porque formamos especialistas para fomentar el desarrollo social de la región, del país y en este caso del mundo. La otra es que las universidades se han convertido en un agente estratégico de desarrollo, no solamente para los países, para la industria. En Estados Unidos es muy claro, pero el resto de Latinoamérica, en Asia, en África, no es tan claro. Entonces estamos siendo como la parte estratégica, ese punto de contacto, ese que llaman el gap, ¿no? Ese punto de unión entre lo que necesita el Estado, la sociedad, y lo que necesita la comunidad. Porque tenemos esa capacidad de formar especialistas que tengan las dos visiones. Estamos formando líderes en la solución de problemas, por lo menos en la propuesta de solución de problemas. Bueno, el asunto es que si lo pudiéramos hacer, por lo menos con dos enfoques mezclados, la equidad educativa y la responsabilidad social, pareciera que es más rápido el progreso social. Pareciera. Si nos vemos como agentes de promoción y desarrollo social, me refiero a las universidades, entonces podríamos lograr este proyecto. Ahora, hablando de salud mental, Voy a retomar una frase de un amigo psicólogo de la Universidad de Pensilvania. Dice, hace poquito, hace unas semanas, tuve una conferencia en Chile y mencionó una cosa interesante. Dice, no hay salud mental, perdón, no hay salud sin salud mental. Esa es la clásica historia. No hay salud mental sin bienestar psicosocial. No hay bienestar psicosocial sin seguridad social. Eso es algo muy interesante, porque a partir del 2015, más o menos, la OMS, la Organización Mundial de la Salud, nos cambia el criterio para construir la salud mental a nivel global. Y este criterio es muy interesante porque ya no es atender al individuo, no es saber que el sujeto tiene estabilidad emocional, necesita estabilidad emocional para poder potenciar sus habilidades, sus capacidades, pero no nos interesa que desarrolle y potencie sus capacidades si él no puede hacer o ella no puede hacer que los demás que están en su entorno modifiquen sus capacidades y tengan bienestar emocional. Entonces, las personas ya no nos interesan como individuos, nos interesan como parte de una sociedad, porque esa sociedad que puede ser capaz de tener salud mental, puede ser capaz de promover la salud mental en otras comunidades. Entonces, en ese sentido, la salud mental no es, y creo que nunca lo ha sido, una cuestión de trabajo solamente individual. Hay que entender cómo se comportan las comunidades, cómo ha evolucionado una sociedad, una comunidad en particular, cómo se mezclan los valores, y ahora con el tema del Internet es más fácil que se mezclen las ideas, para poder promover la salud mental. Entonces, hay un reto que tenemos, por lo menos en el tema de salud mental, en casi todas las áreas de la vida social. En el 2023, la Asamblea General de la ONU aprobó una resolución por unanimidad, una resolución que se llama Mental Health and Psychosocial Support. Mental Health and Psychosocial Support es un proyecto que en 2 semanas más, desde el 28 de octubre, perdón, del 28 de abril, 3 de mayo, nos va a tocar trabajar. Fui afortunado en ese sentido, me toca trabajar con un grupo de expertos en la ONU para saber cómo aterrizar, cómo hacer posible, cuáles van a ser los indicadores para la creación de política pública en sus Estados miembros de la ONU y poder entender la dinámica comunitaria para poder promover la salud a partir de políticas públicas en todas las áreas de la vida social, lo económico, lo rural, lo social, lo de ingeniería, o sea, en lo legal, o sea, en todos los aspectos. Y esta resolución nos da un dato muy interesante porque se va a requerir, y así lo está solicitando la ONU, se va a requerir que todas las agencias de gobierno reúnan en sus equipos para la generación de política pública, para la implementación de política pública, para la evaluación de política pública, a investigadores y promotores de la conducta. En este contexto, psicólogos, trabajadores sociales, abogados, economistas, ¿no? Y bueno, y varios de los que han mencionado aquí. Los promotores de la salud me interesan. Porque va a ser un caso obligado. Estamos esperando que por lo menos de aquí al 2030 tiene que suceder. Vamos a tener otro rol, los que nos interesa o los que trabajamos con el comportamiento. Tenemos otro rol mucho más amplio que el que estamos planteando en este momento. Bueno, porque este tema de la ONU 2.0 es algo interesante, porque después de la resolución que ocurrió en junio del 23, en septiembre o finales de septiembre, que en principio esperaba la semana de octubre, el secretario general de la ONU plantea una circunstancia bastante interesante. Dice, ¿saben qué? Haciendo un análisis en el avance de los ODS, de los Objetivos de Desarrollo Sustentable, nos damos cuenta que hemos avanzado muy poco y no vamos a llegar a cubrir el 2030 los objetivos. Y se dieron cuenta de otra cosa interesante. Estamos haciendo las cosas mal. Administrativamente tenemos que reestructurar. Entonces, a partir de esa fecha, el secretario general de la ONU propone una reestructuración, una reingeniería en el funcionamiento de la ONU. Y lo plantean así, ONU 2.0. Y uno de los, son 6 puntos transversales que tienen que modificarse, tienen que adaptarse. Y el punto número 4 es especialistas en el análisis conductual. Porque planteó una cosa muy bonita. Tenemos tres grandes problemas a nivel global, tres grandes problemas: cambio climático, migración forzada y salud mental. La estabilidad mental de las personas anda mal. Y las tres cosas tienen un factor en común: el comportamiento humano. La toma de decisiones son los que han promovido esos tres factores. Y entonces eso nos da un rol más significativo a los que nos dedicamos a estudiar el comportamiento humano. Insisto, no solamente a los psicólogos, pues trabajadores sociales, abogados, economistas. Nosotros rol en el desarrollo de las sociedades. Miren, uno quisiera pensar que pandemia vino a empeorar la salud, vino a generar un problema más grande de lo que teníamos. La verdad es que no. Lo que hemos estado viendo a nivel global, lo que hemos estado viendo en diferentes escenarios de trabajo global, es que pandemia lo único que vino a hacer es a exponer con claridad lo que ya venía ocurriendo. Los casos de depresión, los casos de ansiedad, los casos de suicidio, el tema de las migraciones forzadas, la violencia social, ya venía ocurriendo. En el caso de Latinoamérica, particularmente en Latinoamérica, el caso del atraso educativo, del no lograr objetivos educativos, ya venía sucediendo. Actualmente en Latinoamérica, hasta afortunadamente, tenemos el peor indicador de todo el mundo. Somos los que tenemos menos avance en temas de calidad educativa. Pero en esta tabla que les estoy presentando, solamente es un indicador de cómo los investigadores se han preocupado por la salud o por investigar sobre la salud mental en las diferentes etapas del desarrollo. Y lo que vemos ahí es que después de pandemia se incrementaron todos los indicadores, ¿no? O sea, se incrementaron las publicaciones en torno a esto. Lo interesante es que antes de pandemia venían de bajada los recién nacidos, los niños, los adolescentes, empezaron a interesarnos más los adultos mayores, ¿no? Pero, y los jóvenes, por aquello de las adicciones, la violencia intrafamiliar y hasta el abandono escolar. Pero después de pandemia, nos interesan todos, pero particularmente los niños y los adolescentes. Porque en ese rubro vamos a tener un problema muy serio, muy serio. Es un estudio que ha hecho la UNESCO, perdón, la UNESCO, la Organización para la Educación por parte de la ONU, donde sabemos que todos los sistemas educativos en todo el mundo no lograron adaptarse a otro sistema educativo durante la pandemia. O sea, todos se cayeron, todos colapsaron. Y el hecho que hayan colapsado, sobre todo en el área de preescolar y en el área de educación básica, hasta primaria o secundaria, nos generó dos problemas serios. Porque en casi todo el mundo, la educación preescolar y la educación básica, lo que llamamos de los 4 a los 12 años de edad, tiene un objetivo particular casi todos los sistemas. Nos ayuda a desarrollar la empatía, nos ayuda a desarrollar las habilidades de socialización, de integración a grupos sociales. Lo que no logramos hacer en ninguna parte del mundo es desarrollar esas habilidades en esos niños. Y eso, los que se dedican a estudiar la conducta sabrán que cuando una conducta se mantiene, se convierte en hábito. Y se convierte en hábito durante 1 año y medio, 2. Modificar esa conducta en los niños, para los que tengan hijos, quitarles el chocolate, quitarles la nieve o el helado, como decimos, es complicado. Si un niño aprendió a no tener reglas, si un niño aprendió a no importarle a los demás, va a ser complicado. Cuando lleguen a la adolescencia vamos a tener muchos problemas de tipo social. La violencia social se va a incrementar. Los suicidios se han incrementado a tal grado, que uno de los temas, son 3 temas cruciales los que vamos a tratar en la ONU en 2 semanas. Uno es el suicidio. El suicidio en la educación superior, por lo menos en la educación superior, se ha incrementado con ganas. En México, hace 3 años, hace 4 años, hizo un estudio sobre el suicidio, las ideas suicidas en niños entre los 8 y los 12 años. Entre los 8 y los 12 años se ha incrementado la ideación suicida o el intento suicida en un 35% en niños de educación básica. Teóricamente es imposible, técnicamente es imposible, pero está sucediendo. Está sucediendo. Entonces, la idea la idea de que la ONU ponga como tema prioritario a nivel global para integrar las políticas públicas en todas las políticas públicas, el tema del suicidio nos indica que algo malo se va a poner en pie. El otro tema es sí, la salud mental, cómo implementamos, cómo diluimos el tema de los problemas emocionales, cómo intervenimos, cómo modificamos la política pública, cómo financiamos los servicios de política pública relacionados con salud mental. Ese es un tema crucial. Y esto pues, da muchas ideas, ¿no? de cómo se han estado implementando las estrategias. Bueno, ¿para qué va a ser útil la psicología o cuál podría ser uno de los roles de la psicología en temas de salud mental? Insisto, y esto es creo que interesante, por lo menos para los ámbitos universitarios. En menos de 20 años, en menos de 10, 15 años tal vez, enfocarnos desde el punto de vista académico en la educación superior, enfocarnos como profesores a formar estudiantes que aprendan teorías, que entiendan el fenómeno local, no va a ser muy útil. Porque la función del Internet y la función de la interacción global a través de redes sociales está modificando nuestros modelos teóricos. No tenemos la capacidad en términos de psicología de las universidades, no tenemos la capacidad para modificar nuestros métodos de investigación y adaptarnos a la velocidad del cambio de las culturas. Ahora la cultura, la moda, la forma de comportarnos cambia muy rápido, diría un teórico europeo. Tenemos una sociedad líquida, es muy líquida, cambia muy rápido. Antes tardábamos un poco más, me refiero a los 80, los 70, tardaban años en cambiar las dinámicas sociales. Ahora es muy rápido. Y no tenemos métodos científicos, por lo menos la estructura del método científico no nos ayuda para comprender un fenómeno, experimentarlo, comprobarlo, y cuando ya hicimos eso, ya modificamos. Ustedes podrán verlo quizá en la siguiente edición del DSM o del ICD. Quizá venga más rápido en la siguiente ocasión, porque va a haber, el ICD cambió casi en un 15 o 20% su listado de enfermedades a enfermedades nuevas. Eso también es muy interesante porque no tenemos esa capacidad desde el punto de vista científico, generar métodos científicos que evolucionen a la misma velocidad que evoluciona la sociedad. Bueno, ¿qué otra cosa? Bueno, por lo tanto, creo que ocupamos psicólogos, ocupamos especialistas en psicología, no solamente que comprendan los modelos teóricos, sino que comprendan cómo se construye, cómo funciona la sociedad. Y va a estar muy difícil, así lo dijo la directora de salud mental en la OMS, va a estar muy difícil que nos alcancen los especialistas para atender a cada una de las personas. Por eso los modelos de transición de la salud mental tienden a ser comunitarios. Y la propuesta de la OMS, o la propuesta en este caso de la ONU, que va a ser uno de los indicadores que tienen que estar en las cuestiones legislativas, es necesitamos movernos hacia las comunidades. Necesitamos que las comunidades aprendan a identificar indicadores de salud mental. Hay que alfabetizar, por lo menos en psicología, pues en salud mental si quieren, a la sociedad, a la comunidad, porque no tenemos tantos especialistas. Entonces, los fondos van a llegar a aquellos proyectos, a aquellos programas que sean interdisciplinarios, que sean internacionales y que tengan una visión de comunidad, de desarrollo de comunidad. Por eso les digo que formar un especialista con un enfoque teórico de cómo funciona el modelo teórico le va a servir para pasar la materia, pero no para trabajar. Entonces, dentro de poco va a ser ese asunto. Bueno, por lo tanto, necesitamos especialistas que aprendan no solamente a comprender cómo funciona la sociedad, cómo evolucionan las enfermedades, cómo se transmiten esas enfermedades que no son de tipo biológicas, ¿no? Y meternos también a entender cómo se puede participar en la política pública. Y no me refiero a una política partidista, ¿no? En el caso de México, ir con un partido actual de gobierno, sino cómo hacer notar lo que sabemos y que lo pueden utilizar otros especialistas, los políticos, ¿no? Particularmente los políticos. ¿Cómo lo hacemos para que nos entiendan y cómo lo hacemos para entenderlos y proponer algo que funcione y que podamos comprobar que funciona? Eso creo que va a ser parte de lo que estamos. Desde hace unos años me toca colaborar con una asociación, se llama Global Psychology Alliance. Somos más o menos 75 países. Está conformado por presidentes de asociaciones nacionales de psicología, pues, más o menos 73, no, son 72 países, y la participación de asociaciones globales de psicología, la Federación Europea de Psicología, la Asociación Panafricana de Psicología, la Sociedad Interamericana de Psicología, y estamos ahí 3 universidades. La Universidad Autónoma de Baja California, representando a México, está la Universidad de Chile y la Universidad de Uzbekistán. Y bueno, hemos estado trabajando, tratando de promover posicionamientos en torno a cómo la psicología puede apoyar y desarrollar la salud mental y, bueno, el desarrollo social. Actualmente, hace una semana, 2 semanas, el 19 de marzo, el 22 de marzo, nos reunimos en Kingston para evaluar lo que hemos estado haciendo desde el 2022 a la fecha y adaptar nuevos proyectos de acuerdo a lo que se está desarrollando actualmente a nivel global, y acordamos que vamos a trabajar obviamente sobre salud mental, sobre cambio climático, que son los temas que ya traíamos, y actualmente el tema de la psicología con respecto a la inteligencia artificial. Es probable que a ustedes ya les haya tocado, sobre todo los que trabajan directamente con jóvenes, con adolescentes, que los jóvenes están prefiriendo interactuar con una computadora, con un programa de inteligencia artificial, en vez de interactuar con humanos, y creen que son sus mejores amigos y creen que son sus mejores terapeutas, y entonces necesitamos normar eso, necesitamos entrar a normar eso. Yo trabajo con ingenieros en computación y ellos fascinados haciendo inteligencia artificial, no hayamos como decirle, ya no lo hagan. Es complicado hablar con ellos sobre eso. Bueno, el otro tema, derechos humanos. Dentro de derechos humanos, un tema central es la migración. El tema de la salud mental de las familias, de los niños, de las mamás. Por último, quiero comentarles sobre 3 proyectos que estamos desarrollando en zona fronteriza con Estados Unidos. Un proyecto que estamos desarrollando junto con la Universidad de Houston, con la Rice University y con la Universidad de Texas. Ya lo sometimos a evaluación. Es un proyecto bastante grande, son $5 millones. Ojalá el señor Trump no nos deje trabajar en ese sentido. Pero tenemos un proyecto, queremos evaluar a 200 madres latinas migrantes, porque nos interesa saber si la salud mental de la mujer migrante, cuando está en proceso de migración, qué tanto afecta el neurodesarrollo de los niños, de los primeros 1000 días de vida de los niños. Es un proyecto muy ambicioso, pero creo que vale la pena. Otros 2 proyectos que estamos trabajando, uno de los proyectos es con la San Diego State University, con la Universidad de California en Riverside, la UCSD, Tecnológico de Mexicali y UABC. A UCSD y a San Diego State les interesa mucho tratar de entender cómo estamos trabajando nosotros un proyecto para identificar a estudiantes universitarios con autismo, con trastorno del espectro autista, para poder tratar de crear programas de intervención y protocolos de identificación, seguimiento, todo esto. Entonces vamos a platicar la próxima semana, el viernes próximo, vamos a platicar a ver cómo podemos hacer un proyecto conjunto para trabajar de los 2 lados de la frontera y apoyarnos mutuamente entre las universidades. El otro proyecto que estamos trabajando también, yo creo que en 2, 3 semanas, creo que en mayo, vamos para allá, el 10 de mayo, es un proyecto con la NAU en Flagstaff, ahí con la doctora Tara Bautista. También está trabajando con el tema de la salud mental de las madres, y bueno, acá queremos hacerlo también de manera binacional, este asunto de la salud mental de las madres migrantes, particularmente nos interesan las madres migrantes. En resumen, bueno, necesitamos trabajar sobre estos aspectos, crear una identidad global de la profesión, necesitamos regular hasta dónde sí, hasta dónde no podemos trabajar. Definitivamente lo que no vamos a poder hacer es trabajar solos, pues nos interesa la interacción, la interdisciplina, regular la ética profesional, la participación en política pública y sobre todo 2 temas principales: el tema de la niñez y la adolescencia y el tema de la migración, bueno, y el cambio climático. Pero creo que esos son los temas que más nos interesan. Y bueno, por mi parte, es todo. Gracias.
Gracias, Dr. Padilla Lopez. Our next panelist is Brenda Sanchez. Brenda Sanchez is the Executive Director of the Southeast Arizona Area Health Education Center, CHEC, where she leads strategic program development, cross-sector partnerships, and sustainability efforts to advance CHEC's mission of improving the health and well-being of rural and underserved communities in Southeast Arizona through advocacy, education, and action. Since stepping into the role in September of 2024, she has led initiatives across 5 southeastern Arizona counties, Pima, Santa Cruz, Cochise, Graham, and Greenlee, with a focus on community health worker development, public health education, and binational collaboration. Brenda began her journey at CHEC as a public health intern in 2018 and has since held various leadership roles, including community health worker, border binational program coordinator, and program manager. She played a key role in developing Arizona's first certified high school level community health worker training program and has contributed to several community-driven projects, including Proyecto Juntos, a nationally recognized NIH-funded initiative focused on improving access to mental and behavioral health services in rural Southeast Arizona. Her work has helped expand access to culturally and linguistically appropriate mental health services, chronic disease prevention, and healthcare resources for underserved population. Brenda has served as co-president of Covina's 2020 to 2022 and on the board of AZ-CHOW 2020 to 2023. She was recognized as an emerging leader in rural women's health in 2022 and inducted into the Delta Omega Honorary Society in Public Health in 2024. Brenda holds a Master of Public Health and a Bachelor's in Spanish Translation and a Bachelor's of Science in Public Health from the University of Arizona. Her passion for health equity, language justice, and mentorship of first-generation students continues to guide her work. Outside of work, she enjoys traveling, exploring local coffee shops, and spending time with family and friends. Brenda's motto is, once a community health worker, always a community health worker. No matter the role, the heart remains the same. Please welcome Brenda Sanchez.
Everyone. Let me see, my two short ones. There we go. Well, I would like to start by saying thank you. I'm honored to be part of this panel, and I really reflected on where I am today. And I feel that it really echoes what has been discussed, and it's how do we build our healthcare workforce? I feel that as someone who went through the pipeline from high school, undergrad, graduate, and now in my professional setting, I feel that the work that is being done jointly in this room is the reason that I am able to stand at this podium. So I would like to give a round of applause to everyone in this room, because without the work that each of you do individually and that your agencies do, we would not have the opportunity to stand at these podiums. So round of applause. So today I will be talking about Southeast Arizona Health Education Center, a little bit about what we do, and how it is that we provide opportunities for other healthcare professionals to come into the communities that we serve. There we go. So who is CHEC? So CHEC has been an organization for 40 years. This is our 40th year anniversary. Historically, CHEC was the regional AHEC for the region of Pima, Santa Cruz, and Cochise County for about 35 years. 5 years ago, CHEC transitioned into a new role as a standalone nonprofit that really focuses on the CHW workforce. As a community health worker, that was really, I was at CHEC at that time, and that was something that my predecessor, Gail Emmerich, really let us take initiative on. The programming that now exists at CHEC was developed by community health workers based on the needs that we saw in the communities that we were serving. Our mission is now to improve the health and well-being of rural and underserved communities in Southeast Arizona through advocacy, education, and action.
But throughout the presentation and my talking points, you'll see that there is still an overlap. Even though CHEC is no longer an official AHEC, we still continue to use that model in the initiatives that we do because we know that the pipeline works, and that is how we bring future public health professionals, healthcare professionals, clinicians into our rural communities. So this is my team. Without each of them, our agency would not exist and our programs would not exist. Everyone at CHEC in one way or another is a community health worker. So I really want to emphasize that all of the initiatives that CHEC currently has are led by people from the community that best understand the needs of their communities. I was born and raised in Tucson. My parents migrated from Mexico 40 years ago. So I was familiar with binational culture. I thought I understood border communities living in Tucson. But as an undergraduate intern coming to Nogales and going out to Douglas, Agua Prieta, Wilcox, I quickly realized that I had no idea what it really meant to be part of a border community. And that is something that I, to this day, still take ownership of, that when I speak on behalf of border communities, that's not my community. I will always rely on the expertise of my team who were born and raised in Nogales, Arizona, Nogales, Sonora, that are proud ambos Nogales community members. And they're really the ones that are guiding the way that we do our work. And even though I spend most of my time in Nogales, in border communities, I will never fully understand and grasp the needs of that community. It's now my unofficial home, but I also just want to be very transparent that I know that I don't know everything and I will never know everything. And that's why my team represents the communities that we serve, because they're the experts. So as mentioned, these are the different areas that CHEC currently works in: Pima, Santa Cruz, Cochise, Graham, and Greenlee. And they're all very unique and very different. And the way that we do work and engage with community members is also very different. Pima County is more urban. We still focus most of our efforts in our rural, underserved regions, predominantly Spanish-speaking areas of Pima County. But the way that we do work in Pima County is very different to how we do it in Santa Cruz County, given that it is right on a border county. But even Santa Cruz to Cochise County, way different. Then we go up north and we go up to Graham and Greenlee. And for me, that I think was one of the most difficult areas for me to adapt to work in as a community health worker. And over the past 6 years that CHEC has been working in Graham and Greenlee, it has been so much fun. And I have found a new love for rural frontier communities and the resilience that exists in those communities. And I know Katie asked if there's any CHWs in Graham and Greenlee. I will be updating that. So as of 4 months ago, we were able to hire a community health worker that is from Safford, lives in Safford, and she is our boots on the ground in Graham and Greenlee. And that has made a world of a difference to how we engage with our communities. When I first started working at CHEC as a community health worker, we were leading the Ventanillas de Salud for Douglas, and Graham and Greenlee was one of our service areas. That was 6 years ago. I remember going out into the community and the Mexican consulate asking us, you need to find Mexican nationals living in the exterior, and we know that they're there. It took us 6 years to find Mexican nationals living in the exterior that reside and are integrated into the communities of Graham and Greenlee. And what did it take? It took hiring a local community health worker who is from that community, goes to church with the Mexican nationals living in the exterior, whose husband works at the same mine as many of Mexican nationals living in the exterior, where me and my counterparts coming down from Nogales to Tucson, we were outsiders. To them, we didn't understand their community. It didn't matter that we were there twice a week for 6 years. It took a community health worker from the community for them to really open up. And I'm proud to say that over the past 2 months, we've been able to hold weekly workshops with Mexican nationals living in the exterior. And last Friday, the Mexican consulate mobile unit went out to Safford and did a workshop on Know Your Rights for 20 individuals. It took us 6 years to find those 20 individuals. So I think it echoes what is being discussed, right? That it's important to build within and find those folks who are willing to stay in the communities. But we as organizations also have to provide them that opportunity and be innovative. 5 years ago, if someone would have said, CHEC is going to hire a community health worker who lives in Safford, but our office is in Nogales, and that's a 4-hour drive, how are you going to supervise someone like that? We have found innovative ways to do that. And I think that that is something that COVID taught us, that we had to adapt and find ways to do work remotely. So Katie, I will be updating that survey. So where does CHEC work? So as community health workers, we work literally everywhere. So wherever the community is, that is where you will find us. Additionally, again, back to that AHEC model of how do we build our own? How do we bring folks into these communities that most need these services? We continue to provide student internships. We continue to partner with our health sciences at the University of Arizona. The College of Public Health continues to be one of our strongest advocates, where every semester we have students that do internships with us, from undergraduate, master's level, and PhD students who come down to Nogales, learn about CHEC, but then they also end up learning about the 5 other counties that we serve. And what we have found is that through these internships, students learn the realities of the communities. Many times, students have never even been to the border, have this conception of what the border looks like, similar to what Priscilla was saying, of the border looks like insert whatever media it is that folks are seeing. But even outside of border, when you think about rural and frontier, many times students think that it's what it looks like on TV, like we're in the wild, wild west. But then we take them out to Clifton and Morenci, which the fanciest Starbucks that I've ever been at exists, next to these mansions. But then you drive 5 minutes and there's people that are living in caves outside of the mine, because there's such a huge disparity between Morenci and Clifton. And when we take students out there, they're like mind blown. They're like, but that's a 5-minute drive. How is it that you have this 5-star Starbucks and then there's people living in mines, or in old mines? And that really just changes their perspective and really helps them understand what opportunities exist for them. An additional initiative that CHEC has been part of for the past 4 years is that we have joint efforts with Yuma County, Yuma Joint Technical Education District, which is an allied health professions high school level program that we were able to create the first high school level state approved training program. So these are high school students that spend 10 hours a week during their school year going to an after school program where they are taught about the community health worker workforce. They're trained as community health workers, and then we take them out into the community. So we want to ensure that these very young students, so these are 16, 17-year-olds that just survived a pandemic and look at the world through a very different lens than other generations. We take them, instead of doing their field experience in Tucson, in Pima County, in urban settings, we have strategically partnered with different agencies across our service area where we take the students every weekend. So these are students that are dedicating most of their weekends to doing their field experience hours, and we're taking them out to our rural communities. So they're going out to Safford, Morenci, Clifton, Winchester Heights, Douglas, Nogales, Amado, Arivaca, 3 Points. And these are students that when they go, they give their parent permission slip to their parents. Most of these parents have no idea where the heck it is that we're taking them. So as the instructor, so I'm a co-instructor, I will get a text from the parents. It's like, Miss Sanchez, where in Arizona are you taking my kid this time? And so this is our 3rd year offering this program. And one of the outcomes that I wish we would have done a pre and post survey on is the amount of students who changed their career track. So these were high school students in their senior year who were applying to undergrad in nursing, medical, bioengineering. And by the end of the program, we had half of the students switch to public health and really emphasize learning about other rural communities and wanting to serve in that capacity and go back into the communities that we exposed them to. And so now some of those students are in their 3rd year of undergrad and they're still in public health. They're looking into the rural health professions program as they're applying to medical school and looking at how can I go back to the communities that we were exposed to. And they've become our biggest advocates for their peers. So now we have students in undergrad who are talking about the experience that they had in high school in rural communities, and their undergraduate counterparts are like, where did you do this? Like, why were you in rural Arizona at 16? But the impact that it had on these young professionals' lives, we continue to see to this day. And additionally, we continue to partner with universities from Arizona and from Sonora, where we provide service learning opportunities for different healthcare professionals, knowing that if we have students coming, for example, nursing students coming from Sonora, they're not able to provide clinical services. But because of the training that they get in Mexico, they are the perfect community health worker to do that level of work within the US. So we partner them with one of our community health workers, and jointly they do health education, referrals to local clinics, and in turn, they learn about each other's healthcare system, and that makes them better healthcare professionals, because when they are interacting with folks within the clinic, then they better understand where it is that folks are coming from. So these are some of the outreach events that our team participates in, again, across Southeast Arizona. We make sure that all of our material is up to class standards, that it's easy to read, it's available in Spanish and English. And additionally, we also have what was known as the Community Health Advocates of Migrant Population Services, CHAMPS, which was a care coordination program within one of the local migrant shelters in Tucson. There we were able to do triage, health education, and care coordination for newly arrived migrants. We had about 24 hours to provide those services to folks to make sure that they were safe to travel across the US. Over the past 4 years, we were able to provide care to over 4,000 individuals. And in these settings, we were able to bring in students to volunteer with us from medical, nursing, pharmacy, and public health. And so, thank you. That is all I have.
For now, we will have some questions. Does anybody have any questions for the panel?
Thanks, Alex. I really enjoy hearing about these service learning opportunities for students across border. I think it is really an enriching experience. And I was thinking when Priscilla was talking about the public health service learning experience. I didn't catch at the beginning. Is that a voluntary participation or is it required?
A little bit of both. As a graduate public health student, depending on the career path that you choose, it'll tell you that you have to complete a service learning requirement. We are trying to make it be across all curriculum, but at this moment, it depends. So what I did not mention is that once a student takes this course, we have so many repeat offenders, like, cause it's so much fun, like, it's so much fun, it's so great. So we have, right now, one of our students, Dora, is on her 4th time taking it, so she's a PhD student, so she's taking it every single year. And the last thing that I wanted to comment, since I have the mic and I love to talk, is that we are looking to expand. So I came into this role 4 years ago as well as a student. I took it as an independent credit and I've been teaching it officially for the last 2 years. But I really want to expand these opportunities for people here because it's really interesting, me as a human, as a local, like to see people from the outside come in and learn so much about my home. It's a little bit vulnerable, if I'm being totally honest. But I want those opportunities to be happening for us here. And so I did reach out, and I didn't have enough time to try to coordinate something with AWC. I saw Dr. Ching here earlier. And so just wanted to say that as I'm learning a lot about other programs that are here, I think this is a really great opportunity that we can expand it into all the other folks here. So wanted to put that out there. But yeah, it depends on the student.
Yeah, I just wanted to comment, when I was with San Diego State, we required it. We call it a study abroad experience. And we required it particularly in the health professions, nursing. And we had a large contingent in those years of RN to BSN nurses, and they fought it tooth and nail. Because every time they would go across the border for this requirement, which is 150 hours, they would complain they were losing shifts and losing money. And so it's a real problem. We hired a retired surgeon out of Mexicali to coordinate the program. And it took about 3 years to really get the nursing students to appreciate it. And they did in the end. But nursing practice is so fundamentally different, in Mexico than the US. And living in the border region, we really felt we had to require the students to experience that, to have a complete education. So anyway, yeah, good luck.
Any other questions or comments for the panel?
Gracias. Buenas tardes. Esta pregunta va particularmente para el doctor Alfredo Padilla. Comentaba usted que próximamente se va a reunir con personal de la ONU para dialogar de diversos temas y uno de ellos sobre cómo traducir la información científica y aplicarla, ¿no?, al ámbito social comunitario. Que yo creo que históricamente es uno de nuestros problemas, ¿no? Tenemos el conocimiento, las universidades están desarrollando este tipo de conocimientos, proporcionan información a partir de investigaciones, pero desde su experiencia, a partir de lo que usted ha trabajado, ¿cuáles pensaría que serían estas estrategias, estas acciones que se podrían realizar para que los tomadores de decisiones del ámbito político ejerzan, bueno, no ejerzan, sino que apliquen o tomen en cuenta las sugerencias que desde la academia o desde el ámbito científico se están proponiendo, ¿no? ¿Cuál considera usted que podría ser una de estas estrategias?
Pues esa es la pregunta de los 64,000. Es un fenómeno interesante porque es un tema global. O sea, los políticos no voltean a ver a las universidades más que para aterrizar becas, ¿no? Yo creo que también es parte del problema. Nosotros mismos como científicos no traducimos el lenguaje técnico a algo aplicado. Hay un fenómeno curioso también a nivel global en términos de investigación. La mayoría de los investigadores investigan cosas que no solucionan problemas cotidianos. O sea, casi no hacen proyectos de investigación en lo práctico. incluso los programas educativos que tienen que ver con trabajo social, derecho, economía sí, pero trabajo social y derecho, por lo menos en Latinoamérica, no son financiados. O sea, no hay fondeo porque no les interesa a los políticos plantear soluciones a largo plazo. O sea, no haya cómo aterrizar eso. Entonces, nosotros tendríamos que buscar una forma de plantearles cómo medir a corto plazo lo que va a ocurrir a largo plazo. Traducir eso, traducir los contextos sociales a un lenguaje de discurso social. Desafortunadamente son muy pocas las personas que han trabajado en el ámbito científico y luego pasan al ámbito político y que han funcionado, ¿no? Que han hecho las cosas que funcionan, las políticas públicas. Pero creo que una de las formas es hacer este tipo de foros, es decir, este tipo de foros donde hay varios especialistas y que vengan los que crean política pública, para, no solamente para que entiendan que es, cómo se implementa la política pública, que, no se, que ese es otro de los problemas. Una cosa es generar una ley a nivel nacional y otra cosa es que esa ley se pueda aplicar en lo particular en una comunidad. Entonces, ¿cómo los funcionarios traducen la ley a una aplicabilidad local? Eso es una cosa muy complicada. Pero bueno, si nos podemos nosotros como científicos acercar a ellos y tratar de decirle en términos no técnicos cómo desarrollar, cómo crear indicadores de evaluación de eso, es posible que funcione, ¿no? Pero no hay una fórmula mágica. Te digo, es una cosa, desde el punto de vista científico o conductual, es interesante que el fenómeno se repite en el mundo. Y desafortunadamente por condiciones actuales es cada vez más complicado proyectar a largo plazo cuando las decisiones de política no pueden esperar tanto. Pero bueno, creo que una de esas es crear foros donde podamos traducir de lo técnico a lo cotidiano, pero con especialistas en el diseño de política pública o con los especialistas en evaluación de política pública. Gracias.
Thank you. Well, before we head out to, I think this is probably the most engaged conference you've ever had. So I wish we had a little more time, but before we go off to lunch, I'd like for the four front tables with the panelists to go first, please. And then we'll start dismissing the other tables. I hope you're all still enjoying your lunch and please continue to enjoy it. A special round of applause and thanks to the ladies at the La Cocina Main Street Cafe for the wonderful lunch that they gave us. Candy and her staff are amazing and they make amazing food and we're so lucky to have them. At this time, we'd like to introduce our keynote speaker, NAU President, Dr. Jose Luis Cruz Rivera. Dr. Jose Luis Cruz Rivera is a nationally recognized leader in public higher education, celebrated for his executive leadership and public policy. As president of Northern Arizona University since June 2021, he has advanced the Elevating Excellence Roadmap to boost access, affordability, and student success. Under his guidance, NAU has reached record enrollment, reformed admissions and financial aid, improved retention and graduation rates, tripled fundraising, and forged statewide partnerships. Previously, Dr. Cruz Rivera served as president of Herbert H. Lehman College and as executive vice chancellor and university provost for CUNY, the nation's largest urban university system. He has also been provost at California State University, Fullerton, vice president of higher education, policy and practice at the Education Trust, and chief student affairs officer for the University of Puerto Rico system, where he advanced to chair and dean at UPR Mayagüez. An accomplished scholar in electrical engineering and computing, he continues to mentor as a professor at NAU. A steadfast advocate for equity, he has testified before Congress, advised policymakers, and secured funding from organizations such as NSF, Lumina Foundation, and the Bill and Melinda Gates Foundation. His leadership has been highlighted in outlets like the New York Times, Like the New York Times, Dr. Cruz Rivera also serves on key boards, including NACIQI and the Arizona State Board of Education, reflecting his commitment to inclusion and the transformative power of higher education. Born in Puerto Rico and educated at UPR Mayagüez and Georgia Tech, his career underscores a lifelong dedication to public service. Please help me welcome Dr. Jose Luis Cruz Rivera.
Good afternoon, everyone, and thank you for the opportunity to address you today. Want to first start out by thanking, of course, our leaders, Amanda Aguirre and Dr. Sabbath, and all of the organizers of this event. And thank all of you, the participants, for doing the hard, important work that has, hard to believe, become even more critical and more difficult to advance um, given the backdrop against which we operate. Just having the words disparities and diverse in the title of this meeting could be cause for alarm for some, but does not in any way intimidate or deter the folks on this call from advancing this critical work on behalf of our border communities and rural communities. I would just like to say a few words about where we are at NAU with regards to advancing the healthcare and the workforce issues that you're addressing today. I know from the agenda that you have had an opportunity to learn about NAU successes in many of these areas. So I'll just give a few words on where we are and where we're headed, and happy to take any questions or comments you may have. So first of all, as you have heard me say in the past, we are very much directed by our vision, which is to be a preeminent engine of opportunity, which speaks to broadening participation for more talent across the state, um, becoming a vehicle of economic mobility, so ensuring that through the education we provide and the support services we provide to our students, that they can graduate and be well positioned for family sustaining wage careers, careers of consequence, and lives of purpose, and a driver of social impact that not only through the work that our graduates will do once they're out in the workforce, but also in the way that we educate them and the way that we engage in scholarship and research and participatory work with our communities. They will be driving, and we will be driving social impact for the betterment of our society. In the areas of healthcare, a few years ago, we committed to doubling the number of healthcare providers in Arizona in areas spanning nursing, occupational therapy, physical therapy, mental health, allied health fields in general. And we are making good progress towards that. In fact, we have increased enrollment in those programs at NAU and our satellite sites, including at our Yuma campus, by 80%. And we're well on track to doubling the number of graduates in these fields by the year 2035. Having gone through this process of really analyzing what the needs of Arizona were and how we could not only enhance or increase enrollment, but also change the mix of programs that we have and the modalities to have, for example, accelerated degree programs for adult learners who may be looking to change careers and would want to fit into one of the very in demand health care professions. But we also came to realize, as you have heard before, that we needed to do more than that. That if we were to serve our rural communities, our tribal communities, our border communities better, we needed to, in addition to the allied health fields and the physician's assistance programs and so forth, contribute to the medical profession directly by opening up a college of medicine that would be dedicated not to the science of medicine or the technology of medicine as our sister institutions are, but more so towards the communities of medicine and how we made sure that we were producing primary caregivers that wanted to serve our rural and border and tribal communities, that had an affinity to do so, and that would be able to do so if we were in a position to provide them with the tools they needed to graduate with near zero debt from medical school and have the placements they need in these communities so that they could develop their practice. And so we embarked in this project a couple of years ago with the support of the Arizona Board of Regents. Um, our esteemed colleague and Vice President Julie Baldwin has been heading these efforts. And as you would expect, we have dealt with many design challenges, development challenges, funding challenges, political challenges along the way. But I'm happy to say here today that we're still on track and that we will have more to say about the initial incarnation of this College of Medicine in the very near future. Of course, the changing landscape in the federal and state environment, policy, legal, social, economic, has thrown some obstacles in our way, not just in the College of Medicine, but generally speaking, in advancing our mission. But we're determined and we will get it done. In terms of other updates around NAU that are perhaps outside of the healthcare and workforce areas more specifically, but that do contribute to our ability to drive those forward. I'd just like to let you all know that we have had an exceedingly impressive last 3 years in terms of our mission. We have not only admitted the most diverse, largest first year entering classes at NAU in the last few years, but we have also reached the highest percentage of in-state students that we serve at 70%. 70% of our students stay upon graduation to work in the state, so they're very committed to our university. The return on investment for an NAU degree is 3 years. In 3 years, our students break even with whatever monetary and time investments they have made in pursuing an NAU degree. We said a few years ago that we were going to focus on student success and workforce rather than having a single-minded pursuit towards research and achieving a Research 1 status. And we did that, but we also ended up getting a Research 1 designation a couple of months ago. So we kind of had our cake and ate it too. So everybody's working really hard at our university. Our message is getting through. All of the metrics are trending in the right direction. On the philanthropic side, which is always a good indicator of how well we're advancing our work and messaging our mission. We have raised over $181 million in the last 4 years, and that's more than we raised in the previous 14 combined. So all is good. The only places where things are not so bright is, of course, in the changing landscape with the federal government in terms of research funding and some other important areas like immigration issues and so forth, and as well as with the state with state disinvestment in our universities, not just NAU, but all 3 universities. Finally, I will say that the Board of Regents, with the recent hiring of Dr. Suresh Karimella as the president of U of A, has asked the 3 universities to work together to get a better sense of what we can do in a more coherent way and more impactful way in Yuma. And so we have been working on several scenarios of how our relationships in Yuma could evolve, and we will be communicating those in the fall. So with that, I'll stop. I'm happy to take any questions folks may have or comments.
Very busy schedule to be
Yeah,
on.
we can.
We heard this morning a lot about the importance of medical residencies in terms of keeping physicians locally practiced. And increasing the number of medical students, I think, is really important. Attracting students from local communities is really important to study and graduate from our Arizona universities. But how can we continue to try to increase the number of residencies also so that we don't train them and then they leave to go to another state?
That's a great question, and that's one of the, in the case of the NAU College of Medicine um, work, it's one of the major design factors that we're taking into account. So, in order to address that, we are building our own coalitions of community service providers. We are in conversations with two major hospital networks that are trying to better um, staff, if you will, or serve rural communities around Arizona. And what we're finding is that, part of the issue that we have is that the current residencies that are available and limited in scope, many of them are uh, being occupied by out-of-state students that intend to leave the state or that are more prone, let me say it that way, to leave the state. And so, how do we work together in the health ecosystem to ensure that um, there are incentives in place for those that actually do occupy these residencies to stay on? Is a subject of conversation. Um, so it's an important question. It's a design question. The legislature is looking into it. We're working with the large and small service providers in Arizona and trying to figure out a way to do this. One other aspect that I will throw out there is we're in conversations with out-of-state universities that have had, uh, they've been able to develop consortia with other states that are seemingly needing students or residencies in rural areas and have a larger portfolio, if you will, of such residencies that are not necessarily being filled because they are not necessarily the most attractive for those that are not looking to serve in those communities. So looking at the possibility of having a hub, an exchange hub, where some of our students could have that access. But it is one of the main design challenges right now.
Cruz Rivera, but with that, we thank you so much for being with us again this year, and we appreciate your time, and we hope that you'll join us again next year. Thank you.
Thank you so much. Bye.
We're about to do a really fun activity, so if you could please make your ways down to your seats, we'd really appreciate it. All right, well, we're gonna proceed. It looks like we've got the majority of people back that are going to come back, so we will move on to health rhythms activity, recreational music making with led by our very own Alex Valenzuela. Alex Valenzuela has been with Regional Center since 2013 and San Luis Walking Clinic. He's a licensed clinical social worker, and we're happy to have him with us to lead us in this. Thank you, Alex.
Yeah, Alex, I hate to start by correcting you, but it's since 2011, so I've been here for almost 14 years, very fruitful years. So I love it, and I get to do fun stuff like the one I'm going to take you through today. So what we are doing, we are going to do more of a wellness activity. It's going to get us moving. Earlier, I thought Steve and Priscilla were going to steal my thunder because you're getting people moving. So hopefully we can continue that and do a little bit more of that. So we're going to go ahead and get started with a lemon passing activity. I think Rudy's going to have a leg up on us since with all the early education that he's done, he's probably done a lot of these circle activities. So what we're going to do is we're going to go ahead, and if you're part of a smaller group, we need everybody to stand up first and foremost, please. All right, thank you. So if you are part of a smaller group that doesn't have at least 5 people, can you go ahead and find the group and a circle? We want to get you to be in a circle. So the instructions would be to be at least an arm's length because you're going to be passing this lemons to the people beside you. So I'm going to go ahead and at one point, I'm going to tell you a little bit about what this curriculum is and what we use it here at the Regional Center for Border Health. But before I get started, I want to introduce my co-facilitator, a very brilliant ASU intern, Mr. Crisanto Reales. So, and he's gonna go ahead and tell us about the instructions here for our first activity. Oh. Is there a clicker? Okay. Alrighty, so go ahead, Crisanto.
As Alex mentioned, this first activity is gonna be the lemon shaker. We're basically gonna be passing these lemons that are in front of you and the circle with your table. So please grab a lemon or a shaker, and if you don't have one, please let us know before we start.
Yeah. Anybody missing a shaker? Everybody got one? Okay. All right, try to work on those circles. I see some oddly shaped circles here. If we can make sure we get into a tight circle, because this is gonna require us to be able to pass the lemon to the person beside us.
Once we have those circles formed, we're basically gonna be taking the lemon from our left hand and passing it on to the right, and then passing to the right to the person next to us. And then once you pass it over to the person next to you, please make sure to take and pass as you pass them on.
So take and pass, you're gonna take it from your left hand onto your right and then pass it, okay? All right, so we're gonna get started here in the count of 3. Are we ready? All right. So remember, pass it, take and pass, and keep going. Crisanto at some point is gonna ask us to speed up the tempo a little bit, so be on the lookout for that prompt, please. Go ahead, so here we go. 3, 2, 1, take and pass.
All right, a little faster now, a little faster.
A little faster.
All right, a little bit faster once more. Take and pass, take and pass.
Rápido, rápido. Quicker, help. I already hear those lemons falling. If you, another thing, if you drop the lemon, don't pick it up, okay? Take and pass, take and pass, take and pass. Come on, speed it up, guys. Speed it up. Take and pass, take and pass. Come on. Don't stop. 15 seconds. Come on, finish strong.
Faster, a little faster. Take and pass, take and pass.
Last 5 seconds. Finish strong, guys. 5 seconds. Come on. You can't stop. There's that lemon waiting for you. Keep going. 3, 2, 1, and stop. Stay upright, please. If you guys can be standing, please. Thank you. So, how was that? You know, some of you did really, really well. Some of you thought too much about it, and someone didn't think anything of it. So I saw a little bit of everything, but we wanted to start this activity. This is part of a Healthy Rhythm the curriculum that we have is called Healthy Rhythm. It's what we call a recreational music making program. So there is no musical talent required to participate in this, you know? When we get into some of the drumming, you will see that there's no music, you know, making abilities required. It's just about having fun. So this curriculum, we use it in our behavioral health department with our patients, but we also use it in the different groups, different meetings and things that we have. It serves as a social activity. So there's a social aspect to it. There's even intellectual stimulation because you have to work those fine motor skills. So I was thinking that Rudy would have a heads up on us. I didn't see that though. I didn't see that. So just like passing those lemons around in a circle, the health of our community, in this case, the lemons, depends on how well we work together. Hand to hand, person to person, seamlessly and inclusively. In the lemon passing activity, any gap or hesitation slows the momentum, causing confusion or even the lemon to drop. Similarly, in healthcare, gaps, whether they're in access, representation, or equity, disrupt care and widen disparities. But when everyone is focused, coordinated, and included, the lemon moves smoothly. We saw some of you tables. I saw this table, Amanda, not just because she's my boss, but I saw some well-coordinated movement on this table. It's a reminder, this is a reminder that when we intentionally involve every single hand, especially the ones that are too often forgotten, we create strong, continuous change. This is what developing a diverse healthcare workforce is about, ensuring that no one is left out. Even when the circle is divided by a border, right? Now that we warmed everyone up and have everybody's blood flowing, it's time to get ready to dance a little bit to the smooth sounds of highly trained and educated administrators, not musicians, right? So for this next activity, you will notice that you all have, you should all have an instrument right by your table. We're gonna ask if it's an instrument that more than one of you can play, we would ask that you play in group. And what we're gonna do is we're gonna try to achieve entrainment. So part of playing music, eventually, if you play, you know, at a constant rate, eventually it starts sounding a little bit better. So as we get started, might not sound as good as what hopefully the end product will be. So for this, I'm going to ask Crisanto once again to give us the instructions to this next activity here.
So once everybody has their instruments, you're gonna be making sure to start with a foundational rhythm. It could be anybody within the group out there. And basically, once somebody starts that the rhythm, or everybody else is gonna follow along and try to mimic it as they go along. And then sometimes somebody might add in a little bit more beats, and then just try to basically work in sequence together to be able to make it as harmonious as possible, which is okay because you know everybody's their first time playing. And then just feel free to have fun with it, explore, do anything you want, just play that instrument freely and just have fun with it.
Yeah. So we're gonna go ahead and get started. I want a volunteer to get us started, and the volunteer is gonna play a foundational beat. So it could be, hopefully it's more than one bang on whatever you have in front of you, something that the rest of us can mimic. So then once the first volunteer goes, then we will have someone else do a beat. And we will try to not only do the beat that they did, but also the person who they preceded. And we'll do that about 3 or 4 times, and then we're just gonna start playing. We're gonna play long enough to hopefully, you know, make something sound good. So we're gonna go ahead and get started. I'd like to ask for a volunteer, someone that would like to, you know, Linda was ready ever since I brought out that truck. So we'll have Dr. Elliott go ahead and kick us off with the foundational beat. Right. All right, so let's go ahead and try to mimic that. Who can, all of us that have an instrument, go ahead and try to mimic that. One more time, Linda, so we can hear it clearly, and then we'll go ahead and mimic it right afterwards, okay? Here we go. Good, good, thank you, thank you. I want to add a second beat to that. All right, so we can hold off, and so we're gonna ask for a second volunteer. And they're gonna do their own beat, but then we're gonna start with Linda's beat, and we're gonna follow with the second volunteer's beat, okay? Let's try to do that once or twice, and then we'll stop to give an opportunity for the third volunteer. So I want someone else to give us a beat, someone that has an instrument that would like to give us a beat. I think Mr. Victor here, Pacheco is ready to go. Señor, por favor, denos lo que usted guste tocar, por favor. Okay, so now we're gonna do Mr. Pacheco's, and then we're gonna do Linda's as well. So go ahead. We're gonna start with Linda, and Linda, you can start us off, and then Mr. Pacheco will follow right after you. And then once you start, we're all getting started with Linda. Okay, we're all mimicking Linda, and then Mr. Pacheco's beat. So let's go ahead and get started. One last volunteer. Right after the last volunteer does their beat, I want to hear maybe a cowbell or something that's not a drum. Let's go ahead and put some of those beats to it, and then right after the volunteer goes, the third volunteer, todos vamos a tocar. Right after the third volunteer goes, and you don't have to follow their beat. You can play however and whatever you want with your instrument. So let's go ahead. We're gonna mimic these 3 beats or these 2 beats. We're gonna ask for one volunteer who's got a cowbell or something that's not a drum. All right, our own Gustavo is gonna go ahead and do the 3rd beat. Okay, so what we're doing Linda's, Mr. Pacheco's, and then Gustavo's beat. Okay, and then we're all gonna play freely. We don't have to do what they did. We can do whatever we'd like to play. So go ahead, Gustavo. All right, let's try to mimic that. All right, now we're going back to the foundation beat, and we're gonna go ahead and get started with the 3 beats. And after we've given one sequence, we're just gonna play like there's no tomorrow, okay? Like these, we're gonna play our hearts out. We're just gonna go at it, and something special is gonna happen here in the next few seconds. So let's go ahead and get started with the first 3 beats if you can remember them, as much as you can remember it. So Linda, go ahead and get us started. All right, let's go. Everybody play your own, whatever you want to say. Whatever you want to say. Maybe try to mimic your favorite song. Go ahead. Sing your hearts out. Wow, give yourself a hand of applause, please. That was beautiful. That sounded somewhere between Taylor Swift and Ramon Ayala. So at first, the room is filled with scattered, uncertain sounds. People with no musical training, holding unfamiliar instruments, trying to find the best place in that noise. It's disjointed, a little messy, even uncomfortable for some people. But slowly, something beautiful begins to happen. People start to listen to each other. They adjust, they find their beat, not because you guys are trained musical professionals, but because you paid attention to one another. You adapted and played together. This is a perfect reflection of what it means to close the gaps in those health disparities. Our healthcare system, like a room full of instruments, often starts as fragmented. Voices are missing, rhythms are out of sync, and some people never get a chance to be heard. But when we commit to building a diverse healthcare workforce, one that reflects the communities that we serve, we begin to move towards something called entrainment, towards harmony, right? It doesn't require perfection. It requires inclusion, trust, and collaboration. Only then can we create a system where every person, regardless of her background, is not just part of the music, but essential to it. So thank you all for participating. Had a good time. Thank you all.
How about a big round of applause for Alex and the crew? Well done, that was really fun. So raise your hand if you were able to go down and view at least 1 or 2 or 8 or 12 posters downstairs, hopefully. Okay, great. So, I need my notes on this. So just like last year, it's important to get your input on what you feel our priority discussion should be. We are about to shift into our roundtable discussions for the rest of the afternoon. And what we'd like you to do is, on the screen, you're going to see a QR code, which will take you to a survey to where you can vote or put into priority order our 4 themes for the day. And let me read those off real quick. I'll try to summarize them. So the first one will be youth support and mental health. And this is, if we look at the research downstairs from folks, it was early identification and intervention for mental health issues, especially in education to prevent academic dropout and improve social inclusion. So that was one topic. Second topic surrounded community violence and cross-border challenges. Community violence is a significant issue on both sides of the U.S.-Mexico border, driven by factors like drug trafficking and systemic disinvestment. So maybe that's your number 1 priority. The third one is family resource centers. Okay, so FRCs are essential for connecting families to needed services. Then the fourth one is culturally responsive programming, programs targeting youth and families must be designed to be culturally relevant. So these are those 4 areas. So what we're asking you to do is to drag and put those 4 items on that survey into your priority order. The top priority will be what we're asking you to discuss this afternoon with your table. Do me a favor, give me a quick, as soon as your table is all done accessing this, can you tell me? Yeah, and thanks to Rudy for setting this up. Or, Deanna, okay, thank you. Now we're seeing some results kicking, so it should be live results showing up for which one is the most common top priority. And folks, no cell service here, so you will need to connect to the Wi-Fi. There are QR codes on the wall, or there's also PRS. With the password is password 2024, but the A is the ass. Password 2024, but the A is the ass. Oh, I'm sorry, on that password, the P is capital P, at sign, SS, or scan the QR code. If we can, let's take about 1 more minute to try to get your vote scanned.
If you don't. I have one question.
Everybody's
All right, folks. Thank you very much. We're going to conclude our voting with that, and it was close, but our winner is mental and behavioral health. So let me get the next part of our directions. Many of you have already begun, so I'll wait for a second.
Give it a chance.
Okay, so with this, scan the QR code. Every table should have one of these pages, and on the laptop, actually, the page should already be linked on your laptop. We ask that you put your names, list the mental health as the priority discussion topic, and we ask that you keep your notes on it. However, here's the trick, and this is where there's a test. When you are done, and we'll give you I'm thinking a 5-minute warning. We're asking that you summarize your discussion in 1 to 2 short sentences, max. You will then scan the QR code or click on the link to Menti, and you're going to paste your 1 or 2 sentence summary of your discussions to the Menti board. Then the last hour of our day, we're going to have each group get up, and you're going to have 2 minutes before we turn the microphone off to read your statement and then share the key parts of your conversation. Because for time, we have to really keep that to 2 minutes. So hopefully that wasn't too much at once, but please keep notes. We will compile these notes and share them with you once the workshop's done. But then post your 2 sentences to Menti and be prepared to have 1 speaker share your 2 sentences and discussion, maximum of 2 minutes. Does that work? All right, thank you all. And wait for hear what you discuss. All right, folks, we are going to go into the sharing time now. So I'd just like to hear, let's say, Dr. Baldwin, can you pick odd or even? Even, okay, we are starting with table 20 and we're gonna go backwards. You're gonna have 1 minute, so be ready to come on up, read your one sentence, and then we are gonna celebrate you and then send you down and bring the next person up. So table 20, do we have anybody at table 20? All right, come on up. And then actually table 19, come on up too. We'll be here. We're gonna go rapid fire. So if we can have a speaker from table 20.
So one of the gaps that we see is that most patients want in-person psych services or Spanish-speaking providers, but it tends to be limited in some agencies or communities. When patients want in-person psych services and we're not able to provide that, we would refer them to any other agencies. But when it comes to Spanish-speaking patients, we have to make sure to provide a translator. Another possible solution would be recruiting students from international universities.
What a wonderful recommendations. Yes, as we're gonna, yes, thank you. Building those cross wide national relationships, you know. Table 19.
We had a great discussion and we kind of cheated. We threw in our summary to ChatGPT to give us an AI. So this is mostly us, a little bit of computer out there, but we just felt stronger collaboration across sectors, ensures shared strategies and resources, enabling more effective efforts and meaningful lasting impact in communities. But we kind of further discussed trying to figure out what specific communities' needs are and basically catering to those needs. And so ChatGPT, you kind of failed us on that one, but it had to get rid of a bunch of things when I said, give me 200 words or less. So, but yeah, strong collaboration, which I feel is what we're doing right now today. So more of this, more of getting everybody in the same room and just having these really meaningful discussions.
Excellent, thank you. We can fit all of the board meetings. All right, table 18.
Into the money stuff. We decided that if you were, in order to retain staff, because there's such shortage, especially in psychology, psychiatrists, that if you provided incentives for the provider and to teach and support the precept training.
Yes, trying to grow that precept and preceptorship. Or option. Thank you very much. Table 16. Why? We're going to come right back to you, collect your words there, and if we can go to the next table.
Right, but the main thing that we talked about was the importance of being culturally sensitive and providing workers professional development trainings to better meet the community's needs and give those resources to the people around our community.
Absolutely, so important. Thank you for that. Once again, we're binational. Okay, next page. See.
Addressing patient-provider ratio and services for under-school-aged children 0 to 5. Solution could be attracting providers that serves rural areas with education and/or training through a CHW focus.
CHW more.
Well, some of the problems that we discussed were that there isn't really enough access to qualified therapists with advanced training due to, number one, rural distances and also medical care who stay inside professional bounds. And some of the alternative maybe solutions that we thought about were that we could uptrain staff with up-to-date therapies and hold therapists to professional standards while more effectively promoting available services.
Let's work our way back.
Pediatric classrooms and for large integrated classrooms,
we could increase the teacher's knowledge by providing training at already existing meetings for children with different abilities.
Well, our topic is mental health and behavioral health, mental and behavioral health. And we identify the main challenges like accessibility to mental health services in the border. So we talk about the broad access to care with the health and mental health services with psychology students instead of Mexico. Perfect.
We saw that all of them were interconnected, but we decided to go with workforce development and education. For everything I was mentioned is interconnected in order to address the mental health, which was our main concern. We had to have training professionals. So we saw the early on interventions from internships, and I like the phrase that was used in one of the presentations, helping students learn realities of their communities. So be early on, and also identifying our community leaders, which are key, sort of like the trainer, and pass on the knowledge and experience.
Okay, so what we wrote is about this information is a big gate. Nowadays we have more information and data about mental health, but we don't think there is enough valuable information. There is a lack of good research or more practical for professionals and interventions. So as a solution, I think that we need more room to discuss and look up to the progress in community.
Our group talks about that there's still a high level of stigma when it comes to mental behavioral health in our border region. So the solution is we need providers who are well trained, culturally sensitive, and responsible to meet the needs of our border region.
That's the comma with a reduction in, there's been a reduction in social and economic infrastructure that is created serious behavioral problems, shown by an increase in depression, anxiety, and other pathologies, especially impacting youth. The opportunity that we identified was to increase the healthcare workforce at all levels, including community health, behavioral health aides that would operate similar to community health workers, but also increase interprofessional practice and that would expand multidisciplinary services and technologies for things like telemedicine and better use of social media.
So what we wrote is that the Yuma community is growing at such a rapid pace and new generation of students can contribute to the current workforce. In doing so, they can bring new programs, new medical providers to meet community needs and specialize in areas that are non-existent.
Great discussion. Half of the table works in Mexico, half of the table works in the US. So we need equity to promote complete access to healthcare. Every member of the health community is a fundamental piece if we look to improve care for our communities. In Mexico, there's a saying, don't get sick. We don't have the services for you, but it's easier if you don't. Healthcare access has become a privilege rather than a human right. We need closer collaboration, particularly in rural areas. We need to promote political willingness from those in power and making decisions. We need to promote teamwork from organizations like the ones that are here today. We need to come together as we have the same similar goals. Let's let aside our ego and close the gaps in health disparities.
until I got nominated. Yeah. Our table had some really great discussions and it mirrored a lot with how everybody else's discussions went. So ultimately, I think it just shows how we're all very like-minded and we're all in the field and we're all working towards that same goal. But ultimately, the key items that we identified is, again, the lack of access, especially in the rural area. The lack of access, that means the lack of capabilities to see a provider very immediately when it's needed. So ultimately, our table decided to dwindle that down to needing more funding to educate professionals, but also to educate our community to get rid of the stigma. So very similar, we identified the gap of quality of care and service, as well as the access to mental health care services, and poor involvement of government services to mobilize resources. We identified the solution being education about mental health at every educational level and community level. So end users and providers know what to expect and claim from these kinds of health services. Last but not least, we had a ton of discussions that were very similar to everyone. There's two things that we found in our discussion that we thought was really important. The first one was cultural stigma from seeing a behavioral or health professional, and three things that we wanted to work on to close those gaps were working with the families of those who have been affected with a mental condition or behavioral condition or issue. Normalizing needing mental health, I think it's a huge stigma of seeing a professional in the mental health field, and we need to normalize it's okay to go to a psychologist or a counselor or a therapist. The third one is integrated services, working with different organizations within our community. And last but not least is more training for our health professionals that can help them connect on a deeper level with their patients. And to do that, we wanted to do continued education that helps our providers with cultural humility skills. So being more empathetic with the community that we work with and being able to connect with them in a deeper level.
Thank you to everyone that was able to give their reports and all very good topics and good points. Before we continue with the closing remarks, I'd like to just remind everybody that the AZAHEC Continuing Education Survey will be being passed out right now. And so if you can please take a minute and fill that out and just leave it on your table and we will collect them before we close the session. And also, I'm going to, before we call up Dr. Nelson and Mr. Ortiz, I'd like to call up a few people just quickly, Ms. Amanda Aguirre, Mr. Palmer, Mr. Sabbath. And then can we have Brenda Sanchez, Dr. Luis Alfredo Padilla Lopez, Ana Montoya, Priscilla Ruedas, Catherine Tucker, Dr. Paul. Could you guys all please come to the stage, please? So we have a special gift for Mr. Palmer, who has been with us for a couple years now, and he will be, I guess, going on to a different position.
I'm hoping to come back next year though.
So from the committee, thank you so much to all of our speakers and thank you for joining me.
Don't worry. I'm for a while.
I'm about to So these are all locally made Colorado River pottery in downtown Yuma. I encourage you to check it out. They're really cool products down there. And the little snacks inside are from our very own peanut patch. So if you have a peanut allergy, wear gloves. Going on with the program, okay, so to close out our program, our closing remarks will be brought to you by Dr. Linda Elliott Nelson. Dr. Elliott Nelson retired as Vice President for Learning Services at Arizona Western College. She also served as Strategic Partnerships, Vinculación, the Dean of Instruction, Division Chair of Modern Languages, and Professor of Spanish at Arizona Western College. Her work experience also involves several years in the international business sector. Dr. Elliott Nelson earned a PhD in education from Walden University, an MBA and an MA in Spanish from Arizona State University, and a BA degree from Northern Arizona University. Her activities have included co-founding the Yuma Youth Town Hall, founding and coordinating the Gifted Summer Academy for 4th through 8th graders, co-coordinating the Binational Conference on Education with Baja California, Mexico, serving on the National Modern Language Association Committee on 2-year colleges, and evaluating employee Spanish language proficiency for the city of Yuma. She was inducted to the Yuma County Educational Hall of Fame in 2024, honored with the Heart of Yuma Philanthropist of the Year Award in 2022 in Yuma County, the Shirley Agnos Legacy Award from the Arizona Town Hall in 2022, the Arizona Women in Higher Education Woman of the Year in 2021, the International Athena Leadership Award in 2019, the Outstanding University College Educator Award from the Arizona Language Association in 2000, and the Teacher of the Year Award from Arizona Western College in 1999. Dr. Elliott Nelson has presented internationally on community outreach and engagement, regional collaboration, partnerships, accelerative learning techniques, and community college trends. She served as the chairman of the board of the Arizona Town Hall from 2015 to 2017, president of the Arizona Historical Society Board during the 2023 and 2024, chair of the Arizona Women in Higher Education Executive Board during 2019-2020, and co-chair of the AZ Transfer Steering Committee and chair of the Arizona Community College Chief Academic Officers, and currently serves on the boards of Yuma Orchestra Association, Yuma Crossing National Heritage Area, the Arizona Community Foundation of Yuma, the AHS Rio Colorado chapter, and the Yuma Regional Partnership Council, first things first, as well as steering committee for Southwest Arizona Town Hall. Her current activities focus on community engagement, education, and development in the Arizona, California, Sonora, Baja California mega region. So it sounds like Dr. Nelson didn't really retire, but help me welcome her anyway. Thank you.
Thanks, Alex. I think you've heard that we have a lot of difficulties here, but there's also a lot of programs going on that give us a lot of encouragement. What I'm going to read to you is a synthesis and summary of your table topics from what I heard from wandering around and also what you've shared with us. So this would be again, a synthesis and summary of what you said. In border areas, there are many gaps that exist in regard to mental health and even general health care services. However, there are no borders when it comes to health needs from our populations. In both the US and Mexico, social problems are accelerating and the system cannot keep up with changing needs. We have entered a period of emotional and vocational trauma. The US border area brings many challenges and healthcare issues. The patient-provider ratio cannot provide enough personal access in rural areas on a timely basis. Many people prefer in-person services, which may not be readily available. There is cultural stigma regarding certain health issues. The healthcare systems in both countries vary greatly. There are also differences in healthcare between urban and rural areas. Language continues to be an issue impacting patients who may need an interpreter to communicate with their healthcare professional. Healthcare providers and educators in the border area need to be well-trained and culturally sensitive and responsible to meet the needs of our border residents and enable patients to be their own advocate. Community health workers can be proactive in reaching out to community members directly. Equity in healthcare can promote and sustain an integral health system. Nevertheless, in Mexico, access to quality healthcare is often available only to those who can afford it. The system bureaucracy in both countries creates an environment that is very difficult to navigate. Funding is needed to support the education of professionals who choose to remain in our local communities. Rural areas struggle with limited resources, which not only make it difficult to reach community needs, but also make it difficult to retain staff and to fulfill paperwork requirements for insurance. Grant resources are available, but many organizations do not know how to navigate the process towards funding. There is free training that exists with some organizations that can help them expand their revenue sources. It is crucial that systems in place listen to communities up close and implement solutions that have been suggested. Engineering can provide tools that can help with certain areas of healthcare that may not have the human workforce to complete them. Telehealth services can also reach patients who may lack transportation resources to meet in person. Community-based programs can reach our populations and their unique needs. Forums like this bring us together to change the stigma of mental health. Collaboration is essential. Everyone matters. We can make a difference. Thank you.
Thank you, Dr. Ali Nasser. Mr. Rudy Ortiz, the First Things First Regional Director. Mr. Ortiz has over 25 years of experience in education and early childhood leadership. Rudy has his master's in the art of teaching early childhood education and holds a credential in certified public management from Arizona State University. Once a preschool teacher, he was the first preschool teacher to receive the honor of Teacher of the Year for the entire San Diego Unified School District. He's currently the First Things First Yuma Regional Director, where he serves the First Things First Yuma Regional Partnership Council. The local 11 volunteers plan and execute an over $21 million budget, which strategically invests in local partners to support the healthy development and learning of the young children in the region. Rudy is also a proud adjunct faculty member of Arizona Western College. In 2020, Rudy was awarded the AWC Associate Faculty Teacher of the Year. Rudy serves on numerous state and local committees, including the Children's Museum of Yuma County and the Western Arizona Council of Governments WACOG Head Start Advisory Council. He is passionately committed to supporting our local economy by enhancing and ensuring the early childhood system is a top priority in Yuma County. Please welcome Rudy Ortiz.
So I know I'm the last one before you guys get out this door, so I'm gonna make it quick, and my voice is not gonna let me talk very long to begin with as well, but can we give Linda another applause, because that was amazing. One of the things that we heard was two key words that really stuck out to me today. Number one, accessibility. That things need to be where we can find them, where they're accessible, right? Number two, I heard in the spirit of collaboration. There are two key terms that no matter what table you went to, kind of came up. The importance of working together and the importance that our family, our community, our citizens know where to find resources. So today, what I have the pleasure to do is to formally announce to you that last year we brought up this idea of what's called a family resource center. A family resource center is a hub, a place that is part of the community, that breathes the culture of that community, that represents, that looks like its community, and that can adapt to meet the needs of the community, that people are not afraid of the stigma, that can come in and get the resources they need, but the resources are also right there.
So what I'm proud to announce really quick is that through a lot of work in the past year, and especially this summer, and I can't take any credit for it, the work in the summer, and I have her stand up, is by our very own Deanna. Deanna, if you can stand up, please. Deanna facilitated the task force that included all local leaders to come together. And what these local leaders did is they identified through data what were the needs and what were the access points and what were the priorities of our community. And through that, there was an institution that kept on coming up, and that was Regional Center for Border Health. We need them at the table. We need them at the table. So Deanna and I came over here and we had a meeting with Amanda Aguirre and said, I think we can do more than just having you at the table. And we're ready to sell this very attractive red Corvette to her and want her to buy that red Corvette of being Yuma County's first family resource center. And we're prepared with speech in the car. And with no hesitation, she said, yes. With no, we left that like that was a little too easy. But Amanda, what we're gonna do is in Somerton on Main Street, what was really that original campus of Regional Center for Border Health, that will now turn into the Family Resource Center, the first Family Resource Center. And everyone talking about our health workers, right? Those will be the people leading that work, but in their belt, now they will have the access of over 50 to 60 agencies locally that will able to be worked in that building to ensure that all of the needs, and what's that term we use in health? That big wheel that we know, what do we call that? The social what? That's how we're gonna meet the social difference of health, because every part of that wheel will be in that building. So I wanna say thank you to Amanda. Amanda, come up really quick. I don't know if you know this, I just learned yesterday. So with that, there was the opportunity to apply for a grant. And that was through Arizona Complete Health. And we just learned yesterday that we won that grant. Yes. So we now have part of the funds that will actually support that ability. A lot of work, a lot of trust. So from the bottom of my heart, this is what true collaboration is. So we can't forget, collaboration takes trust. And I can never thank you enough for allowing me the trust that you had within Deanna and myself to support that grant, but we won it. And now here's the kicker. Here's the big kicker. Not only have we won it, but the grantor agency contacted Deanna and I and said, let's make another one. And they're looking at to put streamlined funding in there to support another one in Yuma. So we have until about August, no pressure, Deanna, no pressure, but we have until August. But our priority right now is to ensure that our first Family Resource Center in Yuma County, in Somerton, will do everything that we all talked about today. So thank you so much.
Thank you, Rudy. Exciting work going on in Yuma County. And with that, I'd like to, on behalf of the Planning Committee, I'd like to thank you all for being here with us today. And a nuestros amigos que vienen de México, de Mexicali, de San Luis Río Colorado, gracias por estar con nosotros. Le agradecemos mucho su colaboración y pues que tengan un buen viaje and everybody drive safe going home. Thank you.